You are most welcome to day 2 of NICON 2025. My name is Donna Traynor and I will be your guide and host for another day of this fantastic conference with a terrific lineup of speakers and discussion sessions along with a whole array of exhibitors outside. With the support of our sponsors, NICON has produced a gathering to inspire, to challenge and to encourage you in the delivery of the Reset plan in our health and social care system. As well as speakers and discussions here in the main hall, we have parallel sessions later this morning on a range of subjects, and I'll give you an example: AI, winter planning and waiting lists, to name really but a few. We have had so many open and honest conversations throughout yesterday, throughout day 1 of the conference, and they will continue today. This really is a place of sharing and a place of collaboration. As professionals, you know that the purpose of the ambitious Reset plan is to stabilise, reform and deliver our health and social care system. Now, we recognise the achievements, in particular, over the past 12 months. We heard yesterday that £200 million has been saved collectively by the trusts last year. That is some achievement, and that has to be recognised. But I hardly need to remind you that the system is still challenged with financial constraints. This is, of course, personal. The reset is for the benefit of all of us, for you, your families, and your communities. And that imperative to make changes, work in a different way, and to safeguard the system for future generations will be addressed later this afternoon by our main speaker here in the hall, Alan Milburn. All of the information, of course, as delegates, that you need, that's in the mini guide and also the main guide for delegates, all the times and locations of all the different sessions. A little bit of housekeeping: no fire drills are planned for today, so if you hear the alarm, it's the real deal. Out the exits and down into the car park. The staff here at the hotel will escort you. And also, I've been asked by the hotel, if anyone stayed overnight here last night, as in a room, they need to check out. I believe the dinner was great crack. They need to check out of the hotel by 11:30, if you could do so. As I said yesterday, and I say again today, this is your conference. Please come and go as you please and get the most out of today. So to open today's conference, please welcome to the stage the Vice Chair of NICON and Chief Executive of the South Eastern Health and Social Care Trust, Roisin Coulter.
Good morning, everybody, and I'm absolutely delighted as the Vice Chair of NICON to welcome you all here today to our second day of our conference. And if you were here yesterday, well, you will know what happened and how fantastic it was, genuinely. Slightly biased, but probably the best NICON conference ever. And if you're just joining us for day 2, the day is full, and I would encourage you to take every opportunity, not just for networking, but for attending the sessions. There have been breakfast sessions, fringe sessions, sessions on into the evening, and the opportunities that we have got for connecting and really working together in partnership, I honestly believe has never been greater than now in Northern Ireland, absolutely, without a doubt. So just in terms of welcoming, I suppose the whole theme for our conference this year is about reset and how we need to work together as a system, everybody and every part of this system, to reset and reshape our health and social care system in Northern Ireland. And this is an absolute pivotal time. The Minister defined the time that we're in now as a watershed year for Northern Ireland, and that has never been, honestly, as critical. Donna has mentioned, and we have mentioned, the financial challenges that are facing health and social care, and I want to reassure everybody in this room and wider afield that we are taking that extremely seriously. We are leaving no stone unturned. We are doing everything we possibly can to make the best use of public money. As mentioned before, we have delivered £200 million of savings last year, and we will deliver over £300 million of savings this year. That has never been achieved before, and it is extremely difficult and extremely challenging for everybody that works in health and social care. So we want to remain focused on what we are here to do, which is keep patients and clients at the heart of everything that we do, to keep them as our priority, focusing on patient safety and quality, and doing our best within the resources we've got to deliver safe, high quality and compassionate care to those who need it. And how we need to do that is by continuing to work together, collaboratively, and we've heard very much as a theme of our conference that we have strengthened our collaboration as a group of chief executives working in partnership with our business colleagues, our local government colleagues, our service users, our community and voluntary sector. And we need to work right across government. We need to ask that every single minister is a Minister for Health, the only way to tackle inequalities. And if you were here yesterday, the input from Professor Sir Michael Marmot, honestly, the key messages in that will stay with me personally for a very, very long time. They were very upsetting, they were emotional, and if you weren't here, do follow up on that presentation. The statistics in relation to inequalities in Northern Ireland, and how if we are going to tackle inequalities, that needs to be at the heart of the change that we need to make in Northern Ireland. We have got to be driven by moving very, very much to prevention, to services and communities, and taking that focus away from hospitals to communities, maximising every opportunity, moving from analogue to digital, and looking at the data. Use the data that we've got. We've got Encompass. We know what's happening with public health and population health. We know that what we're spending and all of the hard work that we're doing in the health service, we're actually making things worse. And that is extremely powerful. The messages that he sent out yesterday in relation to the number of children in Northern Ireland that are living in a house that is cold, the number of children in Northern Ireland who do not have enough food, and the number of people who are on universal credit, and the line that he said, if you are on universal credit, you will get sick. And I just thought that was so powerful. That leads us to where we need to focus, and that's why we need to work right across. We need to work in partnership right across government, looking at housing, looking at fuel, looking at income generation. We need to work together to really reset. We want to do this. This reset plan, it is ambitious, but it is a credible plan. And we are absolutely 100% behind doing everything we can to support our staff who work tirelessly every day in the health service. And we want to stabilise, and we need to reform. And with reform brings disruption and it brings noise. And we've got to lead then with courage and with conviction to do the right thing for the population of Northern Ireland. And then we need to continue to deliver. And together we can do it. And so it's absolutely fantastic today that we have got our First and Deputy First Ministers here. They have come every single year to show us their commitment and their support for health and social care in Northern Ireland. And I hope that today will be an absolutely brilliant day. And thank you all for coming.
Thank you. And as Rushing said, we're delighted to welcome back to conference the First Minister and Deputy First Minister as they set out the Executive's programme for resetting health and social care in line with the programme for government. Now, the Executive has committed to a whole-of-government approach to improving outcomes, addressing waiting lists and tackling those health inequalities that Rushing was talking about, with a focus on partnership, working together, delivery and innovation. So please welcome ahead of their important executive meeting this afternoon, the First Minister, Michelle O'Neill, and the Deputy First Minister, Emma Little-Pengelly.
Good morning, everybody, and it's great to be back. And by all accounts from Donna and Roisin, I missed the great night's crack last night. But hopefully you all spent some time getting to know each other and learning from each other, obviously, because that's what these occasions are all about. It is great to be back. It's always a privilege to be part of the NICON event and to have the chance to address all of you who obviously every day go about looking after so many people and the well-being of others right across our society. Just to say that we are very grateful for all the work that you do day in and day out. So I was reflecting about last year whenever we were here and what I spoke about, and at that stage we were talking about the transformation journey. At that stage we were talking about the plans that we had for changing how we do things. And I don't know about you, but I certainly feel that there's real momentum now in the air, that I feel like we've made such great strides forward. Obviously we still have an awful lot more to do in terms of the transformation journey that we're on, but I do feel a real change in the air in terms of the achievements that have been made, and that's down to each and every one of you. It's down to your colleagues. It's down to all the effort and energy that has went into trying to do things and improve how we do things, improve how we deliver care, and actually do things and change things faster. I mean, you know this, I'm preaching to the converted, but obviously you all know only too well that our health and social care system can't keep working in the way in which it always has. We have to do things differently because the current model isn't sustainable. And that's not a criticism at all of anybody in the room, so don't take it that way. It's very much about a call for honesty and also equally a call for ambition. I have no doubt that our healthcare system is full of dedicated, compassionate people, but we also know that you are all stretched to the limit, and the system itself is very much stretched to its limits. So we need to look ahead with a renewed focus, and I know that's what you're all been concentrating on over the course of yesterday and today. There's so much good work happening right across our health service, and quite often we only ever hear in the media negative stories around health and social care, but actually there's so much good, so much positivity, so much excellent work happening right across. So for me, we're not starting from a standing start. We're actually looking at what works really well and really trying to replicate that. We're looking at how we can improve things. So really, essentially, we're building on what works. And I think that the more we do that, then the more improved we will be. But it's essential that prevention, that early work, the community care, the innovation has to be at the heart of everything that we do, because we do know that the reality is that the waiting list situation is really unacceptable by anybody's standards. And for us, this is a partnership approach, and I talked about that last year, how we as an executive need to work together. It's not just the health minister's role, it's every minister in the executive's role to actually work together to try to change things. We have in our office established a delivery unit within the executive office, and its number one priority from day one is around tackling waiting lists. And we already can see positive threads there. We can see improvements actually in the waiting lists, and that's down to, I suppose from our part, it's about assisting the work that's actually happening. It's about assisting Mark and the work that they're doing around the waiting list initiatives. And for me, it's to really highlight that there is a genuine attempt right across the executive to work in tandem, to work together, to try to change that picture, because behind all the waiting list stats are people. There are mothers, there are daughters, there are aunts, there are uncles. They represent so many people out there across society. So we want to do better, and we're determined to do better, and I believe that we can do better. But we also know that in terms of health and social care, we have to change the focus, and we have to change the focus right back to from treating illness to actually keeping people well. So how do you change that focus, I think, is the challenge. But as I think Roisin referred to it just now, it's about a whole of society approach. So it is about better housing, it is about a well-paid job, it is about tackling poverty, it is about better mental health support. It's about that whole of life approach to supporting people, because quite often the solutions to poor health often lie right outside of the health service. It's all these other factors at play. So our programme for government is very much designed with that in mind. Our programme for government is about putting people first, and it's about putting well-being at the centre of everything that we do. So since we last met, our executive has invested £215 million in our efforts to try to attempt to cut waiting lists. And as I said, substantial reductions already have occurred, and we're on a journey and a trajectory, and we will make that picture even better. We now have the reopening of the access to the EU scheme, so that you can travel to Dublin, for example, and get your costs reimbursed. All of these things together are helping to change the picture. And I think that, for me, there's so many things right across this island that where we work collectively, we can do much better and improve outcomes for people. So certainly we're determined to continue to look at that from that perspective as well. But I think the focus of the conference around Reset, that is about a mindset change, isn't it, for all of us? It's about approaching things very differently. So we have to keep our services and ensure that they're built around communities, not departments. And I think that the progress that we've delivered in terms of being able to bring care more closer to people's homes, like part of our transformation work has been around primary care and multidisciplinary teams. And I think those are essential, bringing physiotherapists, GPs, social workers all into GP practices, bringing that care more closer to people. I think that's a really transformative area of work and something that I want to see replicated even more. And I think that those models actually really help to deliver care right closer and support much earlier and much more locally to people. And I think that's a really, really positive development. So I suppose what I want to say today, we do have an executive later on today. We can't just come to conferences and thank you and say, well done. We can do that, of course, but also we need to back that up with actually supporting you. So one of our topics for discussion at our executive today will be around the pay situation, and we want to work with our health minister. And whilst I'll not jump ahead of an executive decision today, I'm hoping for positive news from the executive. So just to give you that this morning, because for me, certainly we need to ensure that all of those that work across health and social care have the right pay and conditions to do the job that you do so well. So just to say that Emma and I will be champions of that with all executive colleagues in our executive today. So I will hand over to Emma now at that, but just to say again, thank you for everything that you do. I feel that the tide is turning. I feel, and hopefully you feel, that transformation is really something that we all can see in a real meaningful way every day. We of course have an awful lot more to do, but we're on a journey, and we're on the right journey in my opinion. I believe that the reset is that shift in mindset. I believe that we're all on the same page. I believe that we can improve our health and social care system for everybody, and I do believe that we genuinely can achieve a society that's transformed, where we lift everybody up, that we look at this whole of society approach to healthcare, and we don't look at health in a silo, we look at that whole wider community effort. That's my commitment as your First Minister. I want to continue to work with you. I want to work with the Health Minister, and I think that we will do good things and we will transform things, and I can't wait to come back again next year and we'll talk about the journey that we've travelled even over the course of this year too. So thank you very much and good luck for the rest of today.
Thank you, Michelle. And just as the First Minister had outlined, it's such an honour to be with you this morning. I know that all of you in the room know significantly more about the detail of all of the issues impacting you, much more than Michelle and I do. But our role here is somewhat different. I think it is certainly to set out for you the context and to show our full support. But first and foremost, it is an opportunity for the First Minister and I to say a huge thank you to you, every single one of you that is in the room today. I know that it's not easy working within the system. It's a huge system doing so much every single day, but every single minute, every single hour. The scale of what you do is truly incredible. And I also know that that's not always recognised, that doesn't always make it into the narrative about our health service. It's often reflected that the only time that we hear very often of things is when something perhaps doesn't go as planned, it doesn't go right, but we know that that is a tiny minority of what you do. What you don't hear about on the big media scale is all of the many, many, many thousands of people that are helped every single day and have that really positive experience of every part of our health service. And actually, when you're speaking to family and friends, that's one of the things that really jumps out, because people will say, look, I know there's challenges facing the health system, but do you know what? They were absolutely fantastic. To me, I had really fantastic care in that hospital or under that particular treatment plan. So, it is an opportunity for us to be here in person and to say directly to you, thank you so much for what you do. I also recognise that there's been some positive news that have been, in terms of what has been coming out, and that is really, really welcome. Part of our role here today is also to say to you that we are fully supportive of what you're trying to achieve in every part of the system, but also what Mike are trying to achieve in terms of the new leadership in the department, or Mike squared, as I like to call them. And I do think that there's been a really positive energy, and we've tried to emphasise, as we did last year when we were here, our full support for that leadership team in terms of trying to tackle those big issues that we know can dominate and really overpower so much of the hugely positive work that takes place. This year's theme of Reset, Shaping Health and Social Care for the Future could not be more timely or important. We recognise that this is such a core aspect of our public services here. It needs our support. It can't just be left to yourselves within the system and to the Health Minister and the senior management team in the department. It has to be a whole of society challenge to tackle. And as already highlighted by Roisin and by the First Minister, we know that these things are absolutely interlinked. And while we may talk about affordable childcare or more affordable, warm and good homes for people, that might seem very far away from people talking about health waitiness, but we know that you within the system, you can see the connections between all of those things on such a regular basis. And last year I spoke about my optimism for what lies ahead, and I actually think there's been just so much good news as well, all within perhaps some of that more negative message, but so much good news, so much hard work that has been taking place. And we recognise that actually what we're seeing right now is not a product of just what has happened over the course of the last year. We know how much hard work has gone into that for many, many years. And it does take those many years of hard work to start to change that from a public perception as well. But I think it's a really exciting opportunity in terms of seizing what is coming along and trying to reshape and making fit for the purpose what you do and what we do. My optimism remains, and I really do feel like the First Minister has said that I feel that optimism from so many different parts of the system as well. So I wanted just to highlight some figures which some of you will be very familiar with. So 110, that's the average number of babies born in our hospitals over the 2 days of this conference, each one welcomed into the world by skilled, compassionate teams of midwives, doctors and nurses. 80,000, that's the number of GP consultations taking place in the same period. Thousands of people being cared for, reassured and guided every single day. 250,000, that's the number of prescription items dispensed by our community pharmacies over just 2 days, helping people manage their health and to stay well. And that is just such a tiny snapshot. But for most people out there, they wouldn't realise the sheer scale of the work that takes place, supporting people, because right at the heart of this is, of course, people. People very often distressed, needing help, support and guidance, and they find that within a hugely professional service across so many different aspects. The figures are a powerful reminder of the immense scale of the work that happens, the scale of the work that we want to acknowledge and to thank you for today. Every one of us has a story about the difference the health services made in our own lives or the lives of people that we love, the compassion shown, the reassurance given and the lives saved. Our healthcare staff do remarkable work, often in incredibly difficult circumstances. And your dedication and selflessness never ceases to inspire me. And that's why I also welcome the remarks from the First Minister in relation to the issue of pay. A very challenging issue, it seems, every single year. And that's why we are determined not only to champion this issue, to try to seek to get this issue resolved, working with the Health Minister. I fundamentally believe in that core principle of fair remuneration for fair work, that pay parity across the United Kingdom, but also, and I think this is at the heart of it, it shouldn't have to be something that every year there's a sense of uncertainty and insecurity about. We need to fundamentally reset this issue and to give you the certainty that whenever you do the high quality work that you are doing, that you will get that recognised. It doesn't have to be a constant negotiation to simply get what you deserve. And that is something that we are taking forward through the executive, working with the Health Minister to try to resolve. It shouldn't have to be a middle of the year issue. It should be something that is set out and gives you the clear certainty for moving forward. In addition, we will be driving forward right across our programme for government, recognising, as Roisin has rightly said, and you heard yesterday, the impact of those health inequalities and those challenges on public health generally. You're seeing people at very often at the end of or very far into a process around their own personal health, and that is something that we need to tackle. We know that poverty need not mean that you have poor health. There are lots of really healthy people within that demographic, but it does mean that you're much more likely to have ill health. And as Michelle has said, we've established the delivery unit to take a look at this, but importantly, also the work being done by our Chief Scientific and Technology Officer and advisor to really look at the data. All of those changes that have been happening within your systems will provide those really important data sets to allow us to interrogate and to find out what is happening. So much of this, of course, is about personal choice, family choice, community choice, and making positive choices to contribute on the public health front. But it's also to find out what we can do, looking at the data on an evidence-based way to make those big changes so that actually people are staying healthier for much, much longer. And we know that that is better, not just for you in terms of the pressures that you face, but it's much better for the individual and their family in order for them to live those really happy, healthy, thriving lives. So in conclusion, look, thank you so much. It's such an honour to be here. I actually cannot believe it's been a year since we were here last time, and I've no doubt the next 12 months will go as quick, but those 12 months represents so much effort, so much passion, so much optimism across every aspect of the service. I know that this issue can be fixed, but it can only be fixed with working together. We know that you cannot do it alone. You must have the executive and others working with you. We cannot, within the executive or in the system, solve this issue. We need people, we need communities, we need organisations. We need a fundamental reset of culture and attitude to public health and to that support to you. And that is a challenge that I am up to. I'm really looking forward to working with you, and I know that my executive colleagues are the same. So look, thank you so much and enjoy the rest of your conference.
Thank you, Ministers, and thank you for returning to conference. We wish you well in the executive meeting. Great positive vibes there. So I hope you have the collective voice of NICON in your ears when you make those decisions later on. But thank you for being here, our First and Deputy First Ministers. Thank you. So the Ministers obviously can't stay with us, but they talked about having a whole of government approach to making successful changes to our health and social care system. Each department, each trust, organisation and group, well, they cannot work in isolation. They have to work together. They can't be in a silo. So there must be collaboration with the whole system working to unlock better outcomes for patients, service users and providers. And that's what we're going to focus on now in the main room. To focus on, in our morning panel, we're looking at unlocking better outcomes with whole system working. How this is going to work, I'm going to invite the panel to the stage and ask them each in turn to give us their reflections on the theme that we're discussing, and then I'm going to open it to the floor. I really encourage you, we've got roving mics. This is your opportunity to put your statement, put your questions to our panel. So I will introduce them, and then if you can give a collective round of applause. Lord Victor Adebowale, CBE, Chair of the NHS Confederation. Come ahead, Victor, thank you. A celebrated system leader and leading voice on public service reform. We've Roisin Coulter again. Roisin is Chief Executive of South Eastern Health and Social Care Trust. Ian Snowden is the Permanent Secretary at the Department for the Economy. Thank you, Ian. And David Burns is Chief Executive of Lisburn and Castlereagh City Council. Our panel, ladies and gentlemen, thank you. Welcome to them all. So, Lord Victor, amongst his many achievements, he's established Collaborate. We've talked an awful lot about collaboration over the last 2 days. Well, Collaborate is an organisation that specialises in tapping into the energy of communities and working collectively to access innovative approaches and new ways of thinking. So if you could kick us off, Victor, tell us more about change and how that collaboration and change and how the whole system can work together.
I think, first of all, can I just say how pleased I am to be here? I arrived yesterday, and underneath all the serious talk, important talk, what I love about Northern Ireland, what I love about this place, is you just scratch it, there's the crack. And I love it. I love it. I'm coming back next year for a long
You're
period.
more than welcome, anytime.
So, to the question. So, there's two things I want to say about collaboration. Firstly, one's quite technical. The reason why I set up Collaborate is that I used to be the chief exec of an organisation called Turning Point, and before that I was... and one of the things I noticed is how much time we spent bidding for stuff. We used to win about 1 in 4 bids, which is pretty good, actually. But it cost us for each of those bids. And I realised that that money could be spent actually providing services. So I did some work on the cost of competition, and it was significant. And I realised that the people who actually received those services cared about the services, not the processes of competition, however exciting they are. And so I set up Collaborate in order to ensure that we do the boring bit, because competition's exciting. Collaboration, you have to build relationships, of building relationships so that we spend limited resources better on outcomes. And so that's the first thing I need to say. The second thing is that the situation that you have in Northern Ireland is not that dissimilar from the situation we have in England. You have a number of challenges, demographic, economic, and structural, and you cannot solve those challenges by working in silos. You have to work cross silos, you have to collaborate, but the challenge is that you have to change the way you lead, and you have to change the way you lead as individual leaders, from leaders that often have been encouraged to work in those silos, to protect what you do, what you are in your organisations, to leaders that understand the whole system and your impact individually on your organisation, but more to the point, the impact of your organisations on the whole system. It's called systems thinking, and I would encourage you to read a paper by a chap called Peter Senge, who talked about system leadership. And the only way, if you think about the history of the NHS, and I'll say this and I'll shut up, is the history of the NHS started in a small village in North Wales, Tredegar, where people who were less educated than anyone in this room realised that unless they created a system in which they all put money in order to protect themselves from the vicissitudes, the horrors of ill health, which meant poverty, they would all suffer. And they didn't look at one particular aspect of health or care. They looked at health care across the piece and devised a system that Nye Bevan, who was from Tredegar, picked up and created the NHS. And so one of the benefits you have here that we don't have actually in England is that you have the basis for that kind of integrated approach across health and social care. You have the basis on which you can show the rest of the UK, and I do believe this, how it's done right here. And you can only do that by thinking across the system and by understanding the needs of the population first. And I hope we get into some of that conversation as we go.
Yeah, actually, talking about the population, we're very much talking about people to partners in the conference as well.
Yes.
So what about seeing the people, the patients, the service users, the citizens as assets in the change?
Well, they are assets, not least because they're paying for it all, just in case you're wondering. But there are a couple of things I need to tell you. First of all, I did some work on connected care, which is a model, I won't go into it, but it's the means by which you can design and deliver health and social care services that prevent people from going into hospital in the first place. Because let's face it, put your hands up if you want to go to hospital. No, I don't. So how do you do that? One of the things that you can do is, and I've done this, I know it can be done, is design services with people that they're actually involved in delivering, because most of the interventions that prevent people from going to hospital actually aren't that expensive, right? And we evaluated the connected care service, and I need to tell you, it was evaluated by the London School of Economics, and for every £1 you spend in that way with people, you save £4, and that increases in accordance with the deprivation of the community that you work in. So it can be done. The second thing I would say is that a lot of people talk about no wrong door, and the Deputy Minister and the First Minister touched on this in their speeches. But I call it, the real notion is positive and negative value transfer. So what I mean by that is that poor people often have to go to more than one place to get the same service. Middle-class people do as well, but they're much more charming about it because they understand the system, right? But you think about this, for every transition, that person has spent their time and their capital, and the system has spent time and capital on all those different places. So the only measure of progress in the design and delivery of healthcare with people is that you create positive value transfer, i.e. the fewer places they need to go to get healthcare, and you're doing some of that here. It's not that you're not doing it, but it's possible. You know, the better it is for that individual, the cheaper it is for the system, and the better the outcomes are.
Roisin, you mentioned earlier in your introduction, thank you, take that microphone, about some of the achievements that have already been made, and that collaboration, and we look to the future, we're looking for more of it. But can you reflect for us those things that have changed and things that should be recognised in being an achievement?
Yes, and I think that is really important. Part of this conference is to realise, we have come a long way in health and social care in Northern Ireland, and we do deserve to acknowledge that and to celebrate that. And it's really nice to have visitors to our conference from other parts of the UK and Ireland over the last 2 days, and they have been reminding us what a great place this is, actually, Victor. Great place to live. We enjoy living here, we enjoy working here. And we talked about yesterday how Northern Ireland is a small place, small enough that we can have really good relationships and connections when most of us know each other right across health and social care, but also with other sector partners, but also small enough to have a power to change. So that is really, really important. Some of the things that have changed over the last number of years have been how we have really strengthened collaboration, and not just saying it, but actually making that happen. And I am very, very committed to working in partnership with all of our chief executives across health and social care. We have strengthened that collaboration, and we have moved from a culture of competition to one of collaboration, and we have succeeded. That is fundamental, and it is a fundamental change. It hopefully has rippled right across the culture of how we deliver health and social care services in Northern Ireland, working in partnership with all of us as providers, but also in greater partnership with our Department of Health, our SPPG, PHA and BSO. So we are now in a much better place to take all of the things forward that we are talking about in our conference in terms of reset. And what we have done over the last year is we have now moved to try and formalise that collaboration by the establishment of a shared committee in common. There have been a number of sessions in relation to that over the conference, and what that means is we want to really work as one. So it doesn't matter at all that there are 6 trusts and that there's a department, SPPG, PHA, etc. What we are doing is we are formalising that collaboration to enable us all to work together, to plan how we want to deliver services, to agree that we will do it in the same way, to reduce unwarranted clinical variation, to make the best use of public money, to support each other in terms of vulnerable specialties, etc., and to take shared binding decisions as one. And that is really, really great. It is a game changer, I believe, in terms of how we go forward. But that is strengthening collaboration within health and social care. But what we've also been doing, and that is why it is brilliant that we are joined on the stage by our colleagues from business, by our colleagues from local government, that is absolutely where we need to be more. And we have been doing that, but we want to strengthen that. And it'll be great actually to hear from David and Ian in terms of how we have been doing that. We are being successful, but it's not easy. It does take time, it takes effort, it takes hard work, and it takes focus. And sometimes we have to rebalance, or greater, I think, our focus. It can't all be about managing hospital flow, about managing ambulances, etc. We need to really think about how are we spending our time? Are we really focused on population health, tackling inequalities, prevention, supporting the people that live in Northern Ireland to keep themselves well, to take greater responsibility. And collaboration is about, yes, us across health and social care, wider collaboration with everybody in government, local government, our business partners, but also with our public. So supporting citizens, everybody that lives in Northern Ireland, they need to step up and take more responsibility for their health and well-being. And the launch of the document, if you weren't here yesterday, but people to partners, do take a copy and look at that, a unique approach in Northern Ireland to really working in partnership with our citizens who live here. So I do think that that is optimistic. And there are some examples might come up maybe in questions and discussions of some of the things that we are doing in partnership. There was a fantastic session, not sure if he's here, but Michael Wood spoke to us about health linking to economic benefit. And I thought it was brilliant. And what we need to do there is we need to tap more into the business sector, the academic sector, looking at opportunities for research, for service delivery. And we know that our business partners, I've met numerous 4 or 5 different business partners here at the conference, they are actually saying, we want to work with you in health and social care in Northern Ireland. What is the ask? And that's what we need to do. We need to, in a better way, articulate what is the ask. And I do think one of the things that is different maybe now, probably in the culture and the environment in which we're in, is that we want to say Northern Ireland is open for business. We want the freedom, the space to be able to engage in a much better, freer way with our private sector colleagues, with our business partners who have solutions. There are greater solutions out there. So it's about working together in relation to that, and hopefully you'll hear from others in terms of some of the partnership working that we've been doing.
Thanks, Rushing. And on that note, Ian, in regard to collaboration with business and the economy and using innovation which is created here in Northern Ireland that we've all been sharing over the last 2 days, and in fact from the last conference as well. What is the goal? What is the vision in that collaboration with the Department for Economy?
Well, the Department's overall goal is a globally competitive and sustainable economy that works for everyone. So as part of that, the Minister's very keen to promote more good jobs in the economy, and that's more jobs. A lot of this chimes with what was said yesterday about real living wage, about secure employment, about terms and conditions of employment, and so forth. We want to increase productivity in the economy so that we have more high value, high producing, high value jobs in the economy as well. There's decarbonising the economy, and that leads into things like fuel poverty and able to provide a sustainable and affordable source of energy for everybody. And then there's regional balance across Northern Ireland about dealing with spatial inequalities and distribution of economic growth. So a lot of that chimes with what we were talking about yesterday. It's very much in the same kind of set of themes. There doesn't need to be any kind of tension between economic policy and healthcare policy and actually delivering some of the stuff that was discussed yesterday. Now, innovation you mentioned there is a core component of that. If we're going to increase productivity and get higher quality jobs into the economy, then we need to be promoting innovation. Now, we've got 2 excellent universities in Northern Ireland, and they're driving a lot of innovations in their research that they do. I think the Deputy First Minister mentioned the Chief Scientific Advisor that we now have in the civil service, Professor Helen McCarthy, who obviously comes from she's a clinical sort of a background there too, and her interest is in viral technologies and so forth. And she's driving a lot of work across the civil service around science and technology. She created a Northern Ireland Science and Technology Network. She's promoting at the minute, or drafting up a research and innovation strategy. And a lot of that's about what we can do to extract the value of the really good quality research being done at the universities. I think the challenge that we've got, and just to talk to Victor's point about the whole system approach, is that we can input more skilled people, we can input more research and produce more patents, and we can do all of those sorts of things. But if we hit blockages in the system at some point about the adoption of those in the health and social care system, and then all that work doesn't actually achieve the impact that you
And why
want
are
to
there
see.
blockages?
Well, those would be things that there are other policies which may seem completely unconnected, either to economic development or healthcare, but which make it difficult for people to do stuff. So I was upstairs, and if you get a chance, go up and see the Health and Innovation Network section upstairs. And so a lot of those entrepreneurs, some fantastic ideas, homegrown businesses that they're developing here, talk about how difficult it is to get into selling stuff to the Northern Ireland healthcare system, because we have created, whether it's by culture, by design, deliberately for different reasons, I'm not entirely sure where it originates from, but it exists nonetheless, that people are frightened to adopt innovative technologies. They have to go through a formal bidding process. It becomes very bureaucratic. There's no options to test and learn from those kinds of innovations. And all of those entrepreneurs say that they reach a certain size, and the first thing they have to do is look to England or look to the United States or look to Europe. And that's a real blockage in our system. So we're developing all these fantastic ideas. We've got some really entrepreneurial people, but we don't seem to be able to help them grow.
David, we're talking about collaboration and partnerships, and very often we just talk about the Stormont departments and the health and social care system. What is the role of local government or councils in those partnerships with the communities as well?
Thank you for that, Donna. And I'm delighted to be here on behalf of local government today. I just wish more of my colleagues were here just to realise the potential for development in terms of those relationships. Maybe just using a personal analogy, my wife would be the glue of our family. The kids will say to her in the morning, "Where's my PE kit? What am I doing at lunchtime? You pick me up after school," and I'll turn up later on at night and grab all the glory, so to speak. The only time I hear from the kids is at 12:15 when they message me and say, "Dad, put money on my dinner account," followed up quickly by "hurry up." So that's the sort of challenges I have. So when I left the conference last night after 10 o'clock, as I'm driving home, I phoned my wife and she said, get your helmet on, because Carly is in a disaster of a mood, because there was no soap in the toilets in the school and there was no Luro, so she's in an absolute bender. So by the time I get home, I gave her a big hug and we quickly calmed things down. So my wife was like, "Again, you're the good cop and I'm the bad cop." But she's the glue, she's the one that pulls them all together, she's the one that arranges the social things, she's the one that drives them to the sports clubs at night, she's the one that makes sure they engage with their granda and the like, to really make sure we've got that sort of family network built in there. And the reason I use that is that I see local government very much as being the glue with communities. We are the ones that often are at the front line. We're the ones that can act quickly and agile and with flexibility to make the change at the local level. But we're also the ones that sometimes takes a big hit in terms of press stories and the like. It was interesting yesterday, Mike Nesbitt talking about the £600 million gap in terms of funding savings to be made this year. It doesn't necessarily get much coverage in the papers, but see, when there's an abandoned dog in Dundonald, I've had 300 days of hell on this dog. So it's just about the context and how you sell that message to the people. The people are, if I go out to my communities and talk about arthritis or dementia, blank looks. If I talk about dog fouling and jobs and things like that, people come alive. So there's a wee bit just about the context and the messaging around that. And in terms of community planning, local government is the glue in community planning. The community plan is not a council document. It's owned by all the partners, but we are the ones that will do that bit of running and provide the engagement with community organisations and the like to really make that difference. So in Lisburn Castlereagh, we have created multi-agency support hubs to try and reduce the pressure on the amount of people engaging with individuals that have complex issues. We have provided free access to all of our leisure facilities for children who are in care. So getting access to Northern Ireland's best leisure pool, the only ice pad in the whole of the island, all comes free to children in care within the Lisburn Castlereagh area. Alongside that, we're doing a lot of work about village plans. We're working with the housing executive. Roisin's team were present at that to think about what's the role in health in that. How do we take it away from how the appearance of a community looks to actually start to make a difference about some of the big challenges that faces Northern Ireland. And then from an employment perspective, I and my team regularly engage with business. I know that full employment is a challenge for some of our businesses who want to grow, and the skills don't necessarily exist there. But when 27% of people are economically inactive in Northern Ireland, the challenge is, how do we get them back into work? And the data is an issue for me, because I know that 2 in 3 of the economically inactive in my area are females. but I don't know who they are. So the only way I can target them is by putting something out on social media and say, I'm going to run a class, a training class on childminding or classroom assistance, welding academies, gamification and the like. And it's only those who actually take it upon themselves to get in touch with us. If I could get the data of who those people are, what's the medical conditions that perhaps are stopping them, what's their caring responsibilities or the qualifications that they're lacking, I can go far better armed to their door to say, here's how we can help to turn some of that around. So in terms of bringing it back to the outcomes bit, Donna, there's big challenges. Just listening over the last day and a half, there is so much going on in health. There's so many different parts that need fixed, and it's going to take a long time to sort some of those. But use us, if you think there's things that we can get the community's voice up into that in terms of using people as partners, we are there. We will be an active partner for it. The language is really important too. There's a lot of stuff over the last few days. I'm sitting Googling while you're talking just to make sure that I'm picking that up right. How do we make it easy for the community to understand? How do we get their buy-in? And then the data. Let's overcome the GDPR police that exist in all of our organisations that stop us from sharing information. We need to work better together to make actual better outcomes for our people.
Okay, thank you, David, for that. Yes, absolutely. Victor and our local leaders here are just itching to hear your questions. We have a couple of roving mics. If you could put your hand up, please, for any questions from the floor so I can see you in the audience. Over on the left here, if you wouldn't mind. Thank you. And if you wouldn't mind, if you can, stand up and just introduce yourself to the panel. That'd be great. Yes. Hold on a second, the microphone. There you go.
Yeah, I'll go, yeah. My name's Fiona Prescio, and I'm here as a physiotherapist, not working retired medically, and also as a volunteer with the Royal Osteoporosis Society, because we run a group here, the only group in Northern Ireland, I might add. 4 of us run this group for people who have osteoporosis. I myself have osteoporosis. Now, my area of interest is tapping into volunteer groups that support the health system. Like you have diabetes, you have stroke. There's a whole range of volunteer groups. Also people who are pensioners, retired people. That's an area that you could tap into, because you know, when you retire, you feel you're of no use anymore, that you're seen as being finished. But they have a wealth of life experience and a wealth of probably employable experience that they can bring to so many areas.
So again, that's using citizens as assets. Yes. So it's utilising those people as partners. Yes. Is that question directed to Victor? Or anyone in particular?
All of them.
Yeah.
Because what do they feel about that? Just a couple of other things I just want to throw.
If I can just take one question, because I want to go around the floor. But thank you for your question. Victor, you want to take that? Again, it's using those people in communities as assets who are sharing knowledge and sharing experiences. No, it's a voluntary thing. Exactly, and that was very much a theme throughout the conference. They don't have to be paid. It's a valuable treasure of information that they're giving. Victor.
So the answer to your question is yes. When I gave the example of connected care, the way in which connected care works, and David mentioned this, it was really good to have local government on the stage actually, because I think 80% of what affects healthcare has got nothing to do with the NHS. It's got something to do with the services you provide. But, when you talk about data and information, and the example that you gave of women who you were trying to get into services using social media, I was sitting here thinking that in the connected care model, what you would do is when those women come in, you would say, do you know 3 other people that you can talk to who could help us understand their situation And furthermore, we can train you to design services with those people because you are experts in your community. And what happens is people like you and others in your local communities can design bespoke services relevant to the needs of your community. And what that does is that it responds to the notion of equity. And we all know the difference between equality and equity. Equity is about providing services according to what people need as opposed to what everyone else has got. So there is an evidence base there that says you can engage communities because they understand their needs more. It is, in the end, cheaper. It does create quality preventative services. And actually, I know you're pointing out people don't want to be paid. It creates value such that you actually can pay them. And in some communities, one of the things that gets to me is that poor people aren't stupid. They understand, and really understand more than some of the highly paid consultants you use to understand their communities. So pay them for the value they add. Creates jobs, creates pride, creates outcomes.
Roisin.
And maybe just add, a local example. All of the trusts are very keen on working with volunteers, people who want to give back, and lots of people in Northern Ireland do want to give something back. So just a couple of examples, and we need to work really hard to engage. We need to ask for people to come forward and to support. Sometimes they don't always know that we would be open to that, so that is important. But those who are best placed to support people receiving health and care are those with the lived experience. And there's lots of examples, some particularly in mental health. We have peer support workers, we've got Recovery College, we've got people who are coming back who have recovered from addiction, recovered from very, very complex head and neck cancer, for example, and it is so powerful when they are coming alongside us. There are over 350 volunteers in my organisation alone, people of all ages, all walks of life, and I think that is so really, really important. We say that they are part of our SET family. Every trust works in partnership with volunteers, and I think as well, just through the partnerships here, yes, we could do more with not only with our community and voluntary sector, but with citizens. So through community planning, there are lots and lots of groups that we can target into through whether it's support groups and community and voluntary sector, and they are coming forward. That, alongside our service users, are absolutely critical. So your point, it is very well made, and it is really important. It links into the people as partners, as in, you do want to take responsibility and you do want to give something back, and that's really important.
Thanks, Roisin. Anyone else from the floor? Another question? Just behind you there, Heather, as well, if two. Put your hand up there so Heather can see you. Thank you. And then I'll go this side. Thank you.
Hi, my name's Mabon ap Gwynfor. I'm a member of the Welsh Parliament. Thanks for the welcome.
You're very welcome to Northern Ireland.
It's been fantastic, thanks. Victor spoke about Aneurin Bevan, quite rightly. The one thing that many people don't remember or don't realise is that in 1945, Aneurin Bevan was Minister for Health and Housing. Now, we know that housing is has one of the greatest determinants on health outcomes. And we need to improve housing stock. And we've heard a lot over the last 2 days about how departments need to work together, cross-government. So how do you propose working with the housing sector, housing providers, in order to improve health outcomes?
Who wants to take that? David? You see it on the ground in your council area and others, of course.
I see it on the ground, but my background, Mabon, is also in housing. I spent 20 years in the housing sector. And when I worked in South Ayrshire, my department was community care and housing. So through community planning, my housing team played a significant role in joining the dots in some of this stuff. We were finding a case where previously young people leaving care had to leave the children's house at the age of 18 because it became an adult protection or child protection issue. And what would happen is they would be punted into our homeless system. We would provide them with temporary accommodation, and it would just fall apart. I remember one young guy, and it was almost like a new puppy vying for attention, and because he had gone from having many support organisations or people round about him to suddenly having a house on his own, he would, when he knew the support worker was coming, he would spread excrement over all the walls because he knew it meant that for 2 days there would be cleaners in talking to him and things like that. So the system was failing. So therefore, the role that housing plays is absolutely crucial in all of this. It's the engagement. They know the people that are perhaps slightly less well off, but equally the condition of the house, the quality of the house, the amount of fuel poverty issues that exist in the social housing sector. Housing executive and the housing associations have a real big role to play. I don't know if the housing associations necessarily need to sit round a community planning table, but when we start to talk about some of these issues, I think I need all the housing providers in the room, along with health, along with councils, and along with Stormont, who can provide the money to these organisations to really accelerate the amount of improvements that's required to those houses. But the behaviour bit is as much, it's about how you provide support to those individuals, understand what the local issues are, listen to them, and then act quickly. And I think that's a bit that councils and housing associations can do quickly. We've got less bureaucracy, so we can act at pace.
Victor?
The first thing I want to say is how fantastic it is to see the Welsh representatives here. And I just want to pay tribute to Jonathan Patton and Jonathan Morgan, who collectively run the Welsh Confed and the Northern Ireland Confed. I think you provide great leadership. I used to work in housing. I started my career in housing. And housing contributes well over 20% of the health challenges that you're facing in Northern Ireland and in England. And there are the following things, and the Confed's doing a lot of work around neighbourhoods and community, and housing is a core part of that. And there are the following things that I've observed through my housing career. First of all, the question of accountability. I think if you're providing housing, whether it's in the private sector, the public sector, or anything else, the accountability for the condition of that housing and the contribution that that makes to the cost of ill health is something that should be brought forward and put in front of housing providers, regardless of what sector they're from, because it's a net cost. That's the first thing. The second thing, that there is housing shortages across the piece, particularly at the lower end of the economy, and I think we need to be more imaginative about how we resolve those issues. After the Second World War, when housing was a premium, because we bombed quite a lot of it, what we did was that we developed, this is an example, I'm not saying, but we built lots and lots of actually good quality modular homes, some of which are still standing to this day, that people live in. In fact, they're quite stylish in some places. And I think we need to return to that kind of imaginative response to the housing crisis, because if we do something about housing, which actually I think we could do in a 5-year period, you would see the benefits almost immediately to the healthcare, the health of the population, damp, safety, all the things that you referred to. So I do think housing, the things that can be done should be done, and let's just do them.
Thank you, Victor. Over in this side, thank you. If you could introduce yourself to the panel.
Hi, my name's Siobhan Casey. I'm the Commissioner for Older People. I wanted to ask the panel how you've thought about harnessing the experience of older workers in order to, help achieve better outcomes and, better systems thinking.
Anyone in particular to address that to, Siobhan? Maybe Ian, yes?
Yes, somebody mentioned earlier on our I think it was David, mentioned our economic inactivity rate's about 27%. It's sort of been stuck stubbornly at that level for a very long time. Now, some of those people are disabled or in poor health, and we want and have been working quite closely with health agencies to try to get more of those people back into the workplace quickly and see how we can collaborate. And Mike and I have had conversations about how this might work. And then we talk about women returners to the workforce. That's another section that gets a lot of attention. But what doesn't get very much attention is the maybe the early retired section, which has grown quite significantly since the COVID pandemic.
And what age group are you talking about
We're
there?
talking about anybody under the age of 65, really. And so you'll see people in the late 50s have maybe chosen to step out of the workforce. Now, go back to Fiona's point, some of those people then go into volunteering, and they do continue to make very positive contributions to society. But it's also from an economic point of view, it's a massive loss to the economy because a lot of very experienced people are choosing to move out now. A lot of public sector organisations have got the same age profile problem. Certainly in the civil service, we've got this. I think the median age now is something like 49. It means we have a huge number of people will retire and we'll lose a lot of experience, and we're getting quite worried about that loss of experience. And so we need to find ways in which we can support people as they get older to stay in work and maintain.
Or do something different, to bring that expertise, that knowledge and experience to something else.
Yes, so I mean, that's about reshaping jobs, for example. We have partial retirement policies. There are lots of things we can encourage. And in the public sector, we're probably more advanced and progressive on this than some parts of the private sector are. But to encourage employers to think about how they would use and value the older workers that they have. Because if we essentially say by the time you reach, I get to say this now, I'm 57, by the time you reach my age, you kind of say, well, you're getting close to the end and it's time to move you out to pasture.
And I suppose for a knock-on point, of view as well, for those people who have retired as such, for their mental health, for their social behaviour, their social interactions, it's important that they don't just sit at home and do nothing. David, you wanted to come in on that, and then Roisin.
Thanks, Donna. And I was just going to add to what Ian was saying there. Just today at Lagan Valley Island, there is a jobs fair. I know Paddy's here from DFC. In partnership with DFC, we are running a jobs fair for the over 50s from 11 to 1. And the reason we have done that is because when I've been out talking to businesses, what they're saying to me was, I would far rather have someone over 50 who is willing to work from 10 o'clock to 2 o'clock in the day than bring in an 18-year-old who doesn't turn up every Monday morning because they've been out steaming the night before. So there's a bit there about the commitment and the hard work that those that have been through the system bring to the working environment as well.
Yes, Roisin.
And just again, a couple of practical examples, Siobhan. I think your point's very, very well made. And what we are trying to do and what we can do more of is just need to be more flexible and have a different approach. So some of the examples we have, so it's about, keeping people working in health and social care, for example. And last week we were at an event recognising some of our staff who have given between 46 to 52 years of service, in the health service in Northern Ireland. And all of us have that. So we only do that by trying to make sure that we make the health service a good place to work in, and one that everybody feels valued for making an equal contribution. And what we need to do there is making sure that there's absolute flexibility in terms of working patterns, the amount of hours people work, and that's about keeping people in the health service. The other one then is retire and return. Retire and return is a brilliant initiative, and that has really helped us, and it's helped us stabilise and not lose all of the expertise and skills and knowledge. And the third place we need to go to, I didn't know that was happening, David, today, but I think that having ways of recruiting people in a different way. So it's not always about looking on HSC jobs and filling in application forms. We are trying to be a lot more innovative about, linking in, for example, with our local councils and our local further education colleges, to really welcome people and to have a conversation with them and offer them a job on the same day. People, no longer want and have the patience to wait 12 weeks to fill in forms and have an interview and then, talk. It's not all about academic qualifications either. It cannot be. And there are lots and lots of opportunities. And it's wonderful to see, I know, for example, a gentleman that works in the Downshire Hospital in Downpatrick, Brendan, and, he just said, this is my life. I'm keeping on working, Roisin. The porter that runs the Lisburn Health and Social Care Centre, he's not going anywhere, and he's in charge of the Lisburn Health and Social Care Centre.
Good to hear. Of course, it's difficult for some people because at that age they may have caring duties for elderly parents, and so their circumstances change. But if it's available, they should be able to work. A contributor here, if you could just introduce yourself to the panel. Thank you.
Hi everybody, my name is Michelle Tennyson.
Hold on a second, push the microphone up there.
My name is Michelle Tennyson. I'm the Chief Allied Health Professions Officer in the department. And my question links with the question my Welsh colleague asked, and it's around how do housing and health work together? And I'm thinking in particular housing adaptations. And I reflect back to many years ago when there was quite some tension between the housing executive and the health system. And what we did was we created interagency role, where we have an occupational therapist embedded in both systems, working across those systems, and we've been able to create really innovative solutions and policies. That was long-winded, so my question is, are there further potential for creating these interagency rules that will really start to help us break those boundaries between systems?
And not just housing, but it could be
Not just
many other
education,
subjects.
so on and so forth.
Okay. Ian, do you want to take that? Is there that collaboration together? We heard earlier today, but we also heard yesterday from Sir Michael about the ministers. Every minister should be a health minister. That should be at the back of their mind. But is that reflected in the civil service, in your fellow colleagues as permanent secretaries?
Well, I've taken a little bit of issue with that kind of way of thinking, because that suggests that the point of collaboration is to get other people to do stuff for you. And if everybody approaches collaboration with that kind of mindset, then we end up back in the competition space. To go to the point that was made there, I think what the best way to achieve that, and I'm sure there are tons of specific examples. My mother's 87, she's living by herself now. The OT's been very good working with her and got stuff sorted out quite quickly. And I was director of housing 10 years ago, and I know it was very clunky back in those days, and so it's definitely been a massive improvement. But that's because people looked at the needs of the individual, the service user, and said, well, how does it work from their point of view, instead of how does it work from the organisation's point of view. So we will get the collaboration working when we start more commonly to think about from the point of view of the patient, from the older person, from the child, to think about how does their pathway through all of these services work. So Victor mentioned all these touch points, and you have to navigate the system, and it is very complex. Every one of us will know from our own private lives to do this sometimes, and yet we go back into work and reinforce that kind of set of structures in the way we operate. So we need to find a way in the programme for government and across the civil service and the executive to say, well, starting with the citizen, the service user, the patient, the child, whoever it might be, how do we help them get through the service and deliver the policy outcomes that we want to see, instead of thinking about how do my organisation work with this organisation and create a rule which will be funded through this mechanism under this contract for this set of structures and this set of practices and this procurement route, because that's the way you get lost in the system. And then actually attack all of those questions from the point of view is how does that help the service get delivered more effectively?
Yeah, more person-centred. It's funny, I was talking to a Parkinson's charity representative outside who said there's so much data within the health and social care system. We want to help those people who've been diagnosed with that, but we don't necessarily get access to that. So there's a disconnect. So that's important as well, Roisin, that sharing happens right down to community level, charity level, where there's so much good work going on in the ground.
Yeah, and I think, we're working carefully to think about, supporting people we're caring for, wrapping around them, the phrase, what do you need to make your life work? So it's not just about supporting them with their health and social care inputs, it's about appointing someone, a navigator, often someone who works in the multidisciplinary teams in primary care, to say, what are all of your needs? And we are here to navigate that with you and for you. So whether that's linking in, for example, with housing, with transport, we need to do that as one. And it's important and it does work. But there's more I think that we can do in terms of joining up at strategic level. In particular, the comments made about housing, to make sure that we're all responsible for making the best use of public money. So one example, children leaving care is one example. Another example is those who are in prisons in Northern Ireland. They're released from prison on a Friday. They have nowhere to go. They don't have any home. So they often end up offending or involved in a hostel, and they come back into prison on the Monday morning. If they had a home to go to on release, they may not re-offend to get back into the prison. So it's really about joining all of this up in terms of the planning and making it real. And that has been very sometimes clunky in the past. Other examples have been in terms of our ability to deliver infrastructure across government. And that's important as well.
Okay, but Ian mentioned whole system, you mentioned whole system as well. In wrapping up, David and Victor, if you would like to maybe sum up in a short period of time, if you can, that secret of unlocking better outcomes with the whole system approach.
I think there's a couple of things I want to say. It's very hard to sum up such a rich conversation which has taken place this morning. But Michelle, in your comment, reminded me of something which I think we need to remember. Your comment sounded as though it was about we used to have something that we no longer have, and or has been lost somewhere in the process. And I'm reminded of a practice which is think long. The outcome, which you very well described, should be person-centred. The individual and the community should be at the centre of the conversation. That's how you create strategy, rather than as a theoretical construct. You think long, but you learn short. So this isn't the case that in one leap you were there. That's evidenced by the history of the health system. But you learn. You don't leave experiences like Michelle's and the patients behind. You take them with you into the next cycle. You keep the memory of those people alive by learning. That's one of the reasons why we got
building on what's working.
Absolutely. And one other thing I would say is that, I talk about system leadership, and it can become very theoretical very quickly. But I just want to pay tribute to Mike Farrer, and who I've known for a long time. And the reason why I like the way you work, Mike, is that you're not unique. You're in play. You are learning with people about the state of the system, so that you can then stand back and ask questions, relevant questions. And we underestimate the power of the right question to the system. So the question may well be, I have observed by visiting, the health systems, that although we talk about putting the patient at the centre, we still have systems and processes that don't do that. And the question then becomes, if you have a process that isn't connected to a clearly articulated intention, like putting the patient at the centre, why are you doing it? I mean, honestly, why are you doing it? Right? And you could probably stop it tomorrow, save yourself a load of money, and do the right thing. So I think that is an aspect of systems thinking in action. You have to be amongst it, and you have to understand it. The people at the top, even in the best organisations, and there are some brilliant organisations in Northern Ireland, understand about 20% of what's going on, in the best. The people in the middle understand about 30%, but I'll tell you now, the people right at the front line, they understand the remaining 50%. So if you're a systems leader, start there. And I know you're doing that, but the issue is learn faster, do more, and have systems and processes that link to the intention. And for the Confed, which is what I'm here to represent, we're with you, 100%. We're on this journey with you. In fact, I see Northern Ireland as a crucible from which other systems can learn. That's why it's a pleasure to be here. Thank you very much.
Thank you, Victor, for that. And just to sum up, from a local government point of view, we're talking about the whole system and better outcomes. Briefly, if you can, David.
Okay, I'll maybe just use Michelle's example there with occupational health, occupational therapists. My time in Scotland, we had a housing occupational therapist who would sit alongside us when we were designing new houses. So for a lifetime home, you would suggest a lifetime home would work in all circumstances. Occupational therapist would say, do you know what, the rise and fall hob there won't work in terms of the layout of the kitchen. Actually, you need to swap round where the hinge is on that 800mm door. Otherwise, the wheelchair user is going to have problems getting in and out. So there's something about, to Victor's point there, about using the professionals who have have the lived or the worked experience there. But for me, just in terms of that whole system, the whole system is going to depend on a particular circumstance. There's no point in having a housing professional in the room when you're talking about primary care or pharmacy. You're just going to be wasting their time, and you could be using them better elsewhere. But if it's something linked to the house or to the community, there's probably a better role to play. So I think it's about, and looking at that whole system, having the right people in the room who can actually make a difference.
Okay, thank you very much. Ladies and gentlemen, your panel, Victor, David, Roisin and Ian.
Reducing waiting lists is a central priority of the programme for government, and I'm absolutely delighted that we're joined by members of the Northern Ireland Health Committee, as well as key opinion leaders from across HSCNI, whether that be policy, operational, clinical, and our primary care colleagues. We all have the same mission, and that is behind every statistic is individuals sitting on waiting lists for first consultation or for definitive diagnostic and treatment interventions. So we're going to have a very interactive session. I've waited 13 years to be on the other side of the Health Committee table, so I intend to enjoy myself, Philip. Joking. But actually, I think what you'll see through this interactive session, where we'll go through a panacea of topics from mega clinics, waiting well, reimbursement schemes, the role of the Health Committee and its scrutiny and accountability support mechanism. But I hope that you will see a joined-up approach to the waiting lists. And I'm absolutely delighted that we have representatives from other jurisdictions who we will call upon as well, because whilst we often believe this is our problem, this problem exists throughout the United Kingdom, Ireland, and indeed throughout Europe and beyond, as we grapple with the rising demand, the limited capacity, the innovations that we're going to hear about this afternoon, new innovations, expensive drugs, expensive commodities, and all of that has to fit, and that's really, really difficult. Now, for all of you that know Heather Muirhead, you know that she's creative, and the joy I had in telling our panel that they had to bring an object with them, a visual object to give a sense of what they feel either about the challenge of waiting lists or indeed their insight to the solutions for waiting lists. And I can tell you the civil servants were most uncomfortable trying to think about creativity. So what I'm going to do is go rapidly through our panel. They're going to introduce themselves, say who they are, show their visual object, and say why they brought that. But before they do that, as chair, I have the prerogative of bringing my visual. No, I'm not an orthopedic surgeon. I'm far too clever for that. This is my saw, and as you can see with my saw, I don't do much DIY because it's very rusty. I think I left it out in the garden in winter. But I brought my saw because we have to saw through some of the process that at times gets in the way of achieving the actions of delivering a much more efficient health and social care system, but also dealing with the backlogs that we have. So this is my saw, but it's got a dual purpose today. If any of the panel speak longer than I'd like them to, I'm going to start experimenting with the saw. I always thought orthopedics would be easy, so I'll try that as well. I may give the Health Committee a bye ball, but my colleagues know that I'm happy to use it. So let's go, Niall, first. Your mics are at the side of you.
Hi, Niall McGonigal. I am from the Royal College of Surgeons, the Northern Ireland Director here, and by day I am a thoracic surgeon. So I suppose I actually brought two objects because I can't follow rules. But I suppose what I brought was a safety helmet because, well, I'll say what it is first, and probably in true surgical fashion, Mark brought a saw. This is for my chainsaw. because I have a much more powerful saw than him. And the reason I brought this was a reminder, because you do find, I think, all too often in healthcare, and I've seen a lot in surgery, and I've seen a lot in other disciplines within Northern Ireland, is the unintended consequences. We make decisions about services and we say we're going to change services, we're going to move services. We don't often, I think, give enough thought to how that impacts other services. We had a meeting yesterday with Jeanette from the academy, colleges, and some of the other disciplines. Were talking about how one area there had been a change, staff had moved to it and left another part of their service now completely desolate. So my thing is safety. Think about the unintended consequences of everything that we do.
Perfect. Ursula?
Thank you very much. I'm Ursula Mason. I am a GP. My practice is not very far from here. In fact, I think you could probably throw a stone from here to Carridoff, where I work as a GP. I'm chair of the Royal College of GPs in Northern Ireland. And you'll be pleased to know that I do not have a big piece of kit like these guys in terms of saws and helmets, because when you're in general practice, we don't need technical ability in the same way that our surgical colleagues do, but what we do need is the ability to be able to speak to our patients, to communicate with them, and to actually journey with them on the challenges around waiting on a waiting list, from the first point of contact with general practice when someone presents with a problem that needs escalating beyond the care that can be delivered in community, through that referral process into what is the waiting list challenge that we have in Northern Ireland, and then beyond, so how they manage and how they are dealt with while they wait. So all I've brought is my phone and a set of speakers, because this represents what I do every single day for my patients who are on waiting lists. I talk to them. Sometimes it's by telephone, more often than not it's face-to-face, and I use this as a mechanism by which to support them during the time that they're waiting for care that is something that I can't give them. It also represents a bit of hope as well, because you can see it's a smartphone, and lots of our patients are now more and more connected digitally, and there is something really important about that digital connectivity with the system. So getting beyond phoning the GP to find out where you might be on the waiting list that has nothing to do with the GP is a really important part of the conversations that we have to have with patients about their journey. We are the front door of the NHS, but we don't necessarily need to be the call centre for the NHS, which is often what we find day and daily. So it represents a challenge, but it also represents potentially the future, because as our patients become more connected, particularly around the rollout of Encompass, there are real opportunities in terms of actually communication. So that's what I'm going to talk about. Lots of other things in terms of waiting lists, but communication is key, and that doesn't matter whether it's at the front door or the back door.
Thank you, Ursula, and we'll come back to many of the things you've highlighted there. Joanne?
Thank you. I'm Joanne Elliott. I'm the Interim Director of Elective Care and Cancer Policy in the Department of Health. And my object, I have brought with a map of Northern Ireland. So this isn't a school project, but you'll notice that it is a blank map of Northern Ireland, and very deliberately so, because this is about how we can work together as a region and how we can work together collaboratively to tackle our waiting lists and trying to overcome any organisational or structural boundaries that exist. Thank you.
Thank you, Joanne, and I see several chief executives in the room and chairs, so excellent message. Danny?
Thanks, Chair. I have my door key, and this is representative of how I meet my constituents. I meet them in their houses, I meet them on their doors. The issues that they raise to me, predominantly health is the biggest one, and waiting lists is huge. The amount of people that I speak to on doors that are on waiting lists, that are suffering on waiting lists and deteriorating on waiting lists is heartbreaking, to be honest. Some of them are stuck in their houses because of what they're waiting for, and they're not able to leave, and their quality of life deteriorates. and mental health can deteriorate as well. But the other side of having a house is that you can be treated at home, and that we can do services at home. We can do services in our communities where predominantly patients want them to be delivered. So we can prehab people who are waiting for surgery. We can do as much as we can to get them ready, and we can rehab them in the communities as well when they're ready, and get them better and get them mobile and get them out again.
Thank you, Danny. And again, for anyone that sometimes wonder why did Programme for Government look just at waiting lists, waiting lists permeate into every aspect of our health and social care. We've heard it from Ursula, we've heard it from Danny. We're going to hear it, no doubt, as we go through the interactive session around the pressures on the emergency departments, pressures in secondary care. You don't sit static with the condition that you're waiting to be treated on. That progresses with time, and clearly it does permeate into everywhere. So, Lisa.
Thanks, Mark. Lisa McWilliams, Director of Strategic Performance with the SPPG of the Department of Health. Elective sits with me within my portfolio alongside Mark with the waiting list management unit, and the waiting list allocations are managed through our directorate. So I have brought a very small lunar landing module, and I was probably the most uncomfortable about having to bring an object, as Mark has alluded to. And I've brought this for a number of things. One, it's to show the scale. It's the scale of ambition and having to have a clear direction. But actually, in order to have something like travel to the moon and doing it safely, it requires expertise, skills, the whole system working together. There can be no weak links. We've got to be smart working together. Requires innovation, but most of this is technology enabled, and we have huge opportunities within HSC for that. But fundamentally, it only works if it's safe, and so safety underpins all of this. And I think back to a point that Ursula made, it also enables hope, because you have ambition. Clearly we have landed on the moon. We have a long journey ahead, but we should be hopeful. We are seeing some early green shoots that we are making some inroads into our waiting list, so it's about hope as well.
Thank you, Lisa. Sometimes I wish I was on the moon. Lisa, I suppose everyone in the audience is really keen to know, did you build that yourself?
No, and this is not even the one I wanted to bring. This is the baby one, the bigger one that my son would not let me leave the house with, because he said I would drop it. And I said to Rosie, I've lost an astronaut already between the car park. So I did not build it.
Thank you. And again, really delighted that Philip McGuigan, Chair of the Health Committee, is with us. Philip.
Okay, thanks. Philip McGuigan, Chair of the Health Committee, and my party Sinn Féin's health spokesperson. So when I was thinking about what I would bring last night, I actually glanced at a coffee table and seen this old clock that wasn't working. And when I was going to get a battery to put on it, I thought, actually, this is a symbol from a perspective of somebody on the waiting list, because if you're waiting 1, 2, 3, 4 years in pain for a procedure, time stands still. So I thought that was a good thing to bring, and the battery is hopefully all of us and the system, and when we put it in, things will start to work as they should do, and people will see progress. So, Shin.
And thank you, Philip. And again, it's a reminder to us that people on waiting lists permeate into all aspects of health determinants, unable to work, unable to bring in an income, in pain throughout. Philip, I did notice there was a heart in that clock, so I thought you were sharing the love as well. Rosie.
Good morning, everybody. I'm Rosie Hogg. I'm a consultant anaesthetist in the Belfast Trust, a clinical academic, and the current anaesthesia advisor in the Department of Health. So I brought an old school hard drive, basically just to show the example of what data can do. So we talk a lot about data, but we've realized in the last few years with all the work we've been doing on the waiting list that the data is crucial. Who's waiting where? Are they waiting well? But also going forward, what is the risk for having these procedures? We have a lot of patients on waiting lists who actually, whenever you discuss with them, don't want to proceed anymore because the risk is now higher or the actual outcomes are different. So I think it's really critical, rather than just looking at a list of names, is that what's best for each and every patient.
Thank you very much. And again, I want to thank Keith in the audience, for the clerk of the Health Committee, for helping me put this together. So this is interactive. We're going to have lots of questions and answers. Our panel have been very gracious in terms of answering questions. I'm going to start off, if you don't mind, and I'm going to go to Philip first. So Philip, many in the audience may not actually be familiar with the working and I suppose the purpose of the Health Committee. And yet it is a valuable tool that we all need in the delivery of health and social care. So in your role as chair, would you just like to give us a few ideas about the purpose of the Health Committee?
Okay, so I certainly hope it's a valuable asset and tool within our healthcare system. Primary job of the Health Committee is, it's called the Scrutiny Committee, so the title kind of indicates what its main role is. It's scrutinising policy, scrutinising legislation, scrutinising decisions made by the minister and holding the minister to account. And I think that's a very important role that all the committees have, but particularly within health, because health is our most important public service, and we as elected politicians have a very important job in ensuring that we represent the people of the North, the people who elect us, to help bring about good outcomes. And ministers and departments can't do that alone. They need to be held to account and they need scrutiny. But our role is more than that. It's to assist as well when we can, to help develop policy and look at ideas that we think might be helpful. Legislation is, me and Danny are members of the Legislative Assembly, and we will be looking at legislation within the Department of Health now for the remainder of the mandate, and it's vitally important that we do our job effectively to ensure that at the end of that process that the people of the North have good legislation. And also, as you see, if you watch the news, 6 o'clock on a Thursday afternoon when Health Committee is on, we highlight things that are of importance to our population, because, the broadcasters, the news follow the Health Committee. They also have an interest, and we can bring issues of importance to the fore, which also adds scrutiny to that. In terms of our priorities over the remainder of the mandate, shift left, we have decided that we want to actually take a closer look at what shift left means for our population, but also for our healthcare system. Palliative care, we've just completed our report. It's in draft format, but palliative end-of-life care is an important aspect of our health service that we need to get right and improve, and the committee have done some great work in relation to that. Respite service is another aspect of priority for us in the next year and a half, and obviously waiting lists is right there at the top. So waiting lists is a priority for the executive and also for the Health Committee, and we intend to scrutinise that. The executive have given 215 million. That's a lot of money. We want to ensure that it's invested wisely and resource wisely and does what it's supposed to do in terms of reducing waiting lists. So, the likes of yourself, Mark, you've been before the committee. We will have you and Lisa and Joanne before the committee on numerous occasions, I am sure, just scrutinising exactly how what is going on to reduce our waiting lists.
Thank you, Philip. And again, looking around the room, I can see people from charity sector. We do have media in the room, and actually the communication, the Thursday night communication is an important part of that as well. Philip, I'm going to move to Danny, and again, please all keep thinking of your questions. Danny, you wear two hats in many ways. You are a healthcare professional, and you are a member of the Assembly. You mentioned the constituents, and very convenient you brought the door key. What are the issues you're hearing from your constituents on a daily basis? And just given the fact that you've seen it from both sides as such, what would your top three priorities be?
Well, thank you. Yeah, and you mentioned constituents there, and it is where we hear most of the issues coming from. Now, people contact me in my office on a very regular basis, and the number one topic is health, and waiting lists is the biggest one on that. We talk to many people regularly about them waiting on waiting lists for years. And it's not just surgical waiting lists. We do hear a lot of people who are waiting for orthopedic knees and hips and cataracts and things like that. But we also hear from people who are on red flag waiting lists for breast cancer diagnosis or for other types of illnesses that they're very, very serious and very, very concerned about. So, there are really, really serious issues out there. People are very, very worried about how they are and how this is going to get sorted. I know certainly we had a lady who was 10 weeks waiting on a breast cancer assessment, and the target is 2 weeks. So the stress and the worry that puts on her and her family is huge, absolutely huge. And we really, really need to address that and make that better for people. Out of the three priorities, now I had to think about this last night, and just thinking about what we've heard in the Health Committee, and what we need to do is to get the most out of our resources that we have, whether that's theatres, whether that's scanners, whether that's post-anaesthetic care units, anything that we have, we need to use the capacity within that to its absolute maximum so that we can get out of it as much as possible and get as many of those people through the procedures as quickly as possible. The second thing is workforce. None of it works without the staff. We need staff right across every area, and we've heard constantly about workforce pressures and crisis within workforce right across the health service, be that in medicine or in nursing or in any aspect of health service work. So we need to look at retention and recruitment and making sure that we're bringing enough people in, that people aren't leaving before the end of their professional careers for whatever reason. And we need to address any potential cliff edges that are coming up with retirements. So to have a look and see when people may be planning to retire at a certain time, and that we have the numbers in order to get over that and to continue to deliver services. And my last thing was something we've heard again and again, and that's the waiting well. Now, because we have people waiting so long on waiting lists, they do deteriorate. Their mobility deteriorates, their ability to socialise goes down, their mental health can be affected. So we need to address those patients who are on very, very long waiting lists and making sure that they are okay. They're doing everything they can to be as healthy as they can for the procedure that's coming up to them, and so we can get them through it quickly and rehab them quickly afterwards to get them out of hospital. Thank you.
Thank you, Danny, and I've no doubt we'll come back to waiting well as we go into the session. I'm going to move slightly towards policy and operational now, because again, some in the audience, particularly our friends from across the water, may not be that familiar with what we call our elective care framework and the updates that have come from that, and then the operational outworking. So I'm going to start with Joanne. Elective care framework really has brought us to the policy side, the decisions, and I suppose we're then going to look at the operational outworking of that policy. Do you want to tell us some of the key features and maybe some of the early wins, Joanne?
So I'm going to cover the key features, and then I'll hand over to Lisa for some of the early wins. So the elective care framework sets the strategic direction of travel for how we're going to tackle our waiting lists on a sustainable basis. So it sets out how we're going to build capacity within the health and social care system, how we're going to tackle the backlog of patients waiting, and how we are going to target the investment that we have at our disposal accordingly. So when we look at building capacity in the system, it's looking at how we maximise our infrastructure, how we look at our workforce in terms of its skills mix, recruitment, retention, training, and how we look at the services that we're currently delivering, and whether we need to review and transform some of those pathways or services in their entirety to ensure that they're delivering the best outcomes for patients. The elective care framework describes then how we will use any non-recurrent funding that we have available through the likes of waiting list initiatives to tackle the backlog of patients waiting. It very much recognises that given the length of our waiting lists, we're going to need to have partnership working with the independent sector over the longer term, and it sets out how we can engage with the independent sector on a sustainable basis, ensuring value for money. It looks at how we as a system need to be both productive and efficient, and that's all about maximising the resources that the health and social care system has at its disposal. It also looks at how we communicate with our patients, and one of the policy developments that it describes is a waiting well policy. and a grant scheme to support patients as they wait. So hopefully some of these messages align with Danny and the priorities that he cited in terms of capacity, workforce and waiting well.
Thank you, Joanne. Lisa?
And I'll just touch on some of the early deliverables, early days, and as I said earlier, the scale isn't underestimated. But the waiting list initiative funding that has come through the programme for government has enabled a number of strands of targeted action, which is probably the first time for a number of years. So we have an ability to build recurrent capacity for our time critical and red flag, and we're working through how we commission those additional diagnostics, the theatres, the additional workforce to do that. But in parallel, we have been using additionality both in-house, in sourcing and with the independent sector. So for our red flag and time critical, in the 5 months to date, we have just over 100,000 individuals have gone through either assessment, diagnostics or treatments. But we're in parallel for the first time also trying to target our very long waiters, because for a long time we have focused all additionality on red flag and time critical, which means the urgents wait longer and routines wait really long. So we actually have within the Electrocare framework implementation plan, targets for anyone waiting over 4 years. Now, 4 years is still too long, still unacceptable. But when we start with 8 and 9 year waiters for treatment and 8 and 9 year waiters for assessment and 6 to 7 years for treatments, we had to make a start in this. So to date, and again in the 5 months to date, we have reduced the over 4 year outpatient waits by 24% and treatment waits by 33%. There are specific targeted procedures within that have seen improvements in around 40% for some of the adults. So we are starting to see it for tonsillectomies, for example. But then we've also targeted those developmental pediatric waits. They're not our very long waiters, but we have, PEG tubes and that are maybe waiting more than 13 weeks. So we have been making real inroads in those very developmental. So pediatric scopes have improved, pediatric squints. We have seen great movement in that. And then moving back to the diagnostics, we have already seen, if we look back to our peak of waits for anyone waiting for endoscopy, for that diagnostic component, which in the main rules out or rules in cancer. So a huge volume of patients waiting for scopes. We have seen a 58% reduction in waits when we look at the peak in 2022. And we've done that through the regional endoscopy centres, so the investment that came through the Electrocare framework. So in doing this, we are working to build our recurrent capacity for theatres and imaging, but wrapped around that, we have a very strong efficiency and productivity programme. Back to the point that Danny made, we need to make sure we're using it smartly. We need to make sure that we are sweating the assets. So we have a huge programme actually driving efficiency and productivity. Underpinned by that, Rosie will probably talk about the work on pre-operative assessment, but we know that that is a key area of focus to make sure we have the right people waiting in the right place to be treated and for the right procedures. And we are investing in the skills mix because we need to move away from a very traditional model and a very linear model. We need to make sure we use all of our expertise. And we have really good practice of AHPs running orthopaedic outpatient clinics in certain body parts, so the surgeon is released to be operating on those people who need to be in theatre. So we're really trying to be innovative, and we have some early shoots in bringing the 4 year waiters down. Then we'll move to the 3 years. Then we'll move to 2, because we have to get our waiting list in a better position in order that the system works better from the very start all the way through to the end.
Thank you so much, Lisa. And again, some of the capacity building, the elective overnight stay centres, the day procedure centres. Jennifer has come over from the Doctor magazine and had a trip around one of our elective overnight stay centres. Winter pressure seems to be a topic today, and yet these elective overnight stay centres are unaffected by pressures such as winter. Before I go to our clinicians, and actually for those in the audience that are very observant, we did a random seat allocation, but isn't it interesting that the surgeons on one end and the anaesthetists on the other end, I don't know if that was by chance, but I was thinking of the blood-brain barrier that we often talk about. I see Raymond in the audience there. So before we go to our clinicians, we have a roving mic, and I wanted to see if we had any questions either for our political leaders or our policy and operational leaders in the system. And Cleona's hand shot up amazingly quickly. Say who you are if you don't mind.
Yes, of course. Cleona McSherry, the Policy Manager at the Royal College of Occupational Therapists. Big focus this morning on elective and outpatient waits, which obviously is a huge challenge, massively important. But I wanted to ask the panel for any reflections on community waiting lists too. From an occupational therapy perspective, we have some children in Northern Ireland waiting up to 3 years to see an OT. That's 3 years that they're potentially not engaging with school, not engaging in their household with their communities as well, having real impact. There's been a huge focus over the last couple of days on shift in care left, which is so welcome, but I wonder if anybody has any thoughts on how we get the community waiting list down as well. Thank you.
And I think that's a really excellent point, because we sometimes always think waiting lists mean surgery or procedures. Waiting lists are in all aspects of our health and social care. And again, it's why the tagline, "We need all the help we can get," really includes our wonderful AHPs, our community and voluntary, etc. So who would like to start with this question? I'm glancing probably towards Ursula, who we haven't introduced just yet, but community, shift left, waiting lists in the community, how are we addressing those?
Yeah, so that's a very timely question, Mark. I think it probably encompasses some of what I was going to talk about in terms of, beyond the surgery and beyond the procedure, because the vast majority of patients who present to me don't necessarily need a surgical procedure. Yes, they might do, but we have huge waiting lists around other aspects of elective care delivery, from a medical perspective, but also from a community and an AHP perspective. And one of the big challenges around that in community and shift left is we've seen, the introduction of multidisciplinary teams across parts of Northern Ireland. Obviously, from an OT perspective, and OTs aren't part of MDTs, but it's just a way of illustrating the fact that, service provision across Northern Ireland is not equitable. There are opportunities to shift left, but there needs to be a desire to engage in that and ensure that we're rolling that out across the system so that patients everywhere have equitable access to services. The big challenge is meeting patients where they are, because as Cleona quite rightly puts out, that often, and I think Philip's use of a clock is very apt, because people do just sit and wait, and often time does stand still for them, or in some cases they go backwards and they get more unwell, and the impact of that is huge. So I don't have an answer for Cleona, but I do know that certainly from the patients that I would see day in daily, this is a big challenge where you've got, and also patients who are on multiple waiting lists. So it's not an uncommon thing to be on 2 or 3 or 4 waiting lists, and the fact that you're on one waiting list probably increases your chances of needing to go on to another one. I'll come back to some other aspects later, but...
And then Philip?
I mean, I'm not going to give you an answer either, Cleona, but I was at a wake a couple of weeks ago, and everywhere I go now, people either talk to me about GAA or my role in the health committee, but I get a tap on the shoulder anyway, and I was told, whenever anybody's talking about doctors and nurses, don't forget allied health professionals. And that, message kind of hit home to me that, we talk a lot about whole systems and treating people where they need to be treated. Allied health professionals are absolutely key in that. So in terms of this conversation, they're key as well, and we cannot forget about the role that they can play in it.
Absolutely, Philip, and I'd go further and say, and again, it was in Bengoa, our voluntary and community and our charities actually also do a massive amount of the lift for us in the community, and sometimes I wonder if we didn't have them as well, just where we would be. One more question before we go to our clinicians? Oh, now Sarah might have got there first. We might do two. The clinicians, they'll talk all day, so.
Sarah Christie, Nation Lead at Macmillan Cancer Support, so very timely. Just when everyone was talking, I done a search on Macmillan's online community for the term waiting lists, and it returned 45,555 results. So very pertinent in people's mind. But I wanted to read out something that a person articulated about the impact of their weight in terms of head and neck cancer. I have nightmares every night, and I can't talk to friends or family because I've always been a happy, positive person in their lives, and I know they find it difficult to know how to be around me when I'm not positive. This last year has been really difficult. So my question is, how do you envisage managing important messaging about waiting and waiting lists through non-traditional channels such as online community forums and support lines, which are where people really turn to when they're desperate?
Thank you, Sarah. And again, thank you for making it real, because that is the case. It's people and people suffering. Lisa, do you want to start with that in terms of the whole communication and information?
I will, and I think Joanne will probably want to come in on the Waiting Well initiative as well. And you have touched on it. We use very traditional methods at the moment. You know, we have tried to be more open and honest and transparent about the length of time people are waiting using the My Waits webpage, which uses average weights. We are now going to adapt that. We have approval to adapt that to show the top decile of waiters, because the average is always going to mask a long wait. So that's the traditional way of putting information on websites, putting it on the bottom of correspondence that comes out. And as a sector, we are better using our working with our community and voluntary partners to actually do that more innovative work. But Joanne, you'll want to pick up the My Waiting Well initiative, because it touches in that space.
Yes, thank you. So as I mentioned, as part of the elective care framework, we are committed to developing a policy on waiting well, and that policy is currently in development. But that is all about how we support patients who are currently on waiting lists for treatment. And it's very much about how we are going to work collaboratively with our trusts, our patients, and our voluntary and community sector organisations to help to support patients in their time of need while they are waiting on waiting lists, helping them to stay healthy, making sure that they are getting the information that they need at a time in which they need it. And making sure that that information is provided to them in as targeted a way as possible. And as part of the work that we're doing under the elective care framework, we're also developing a grant scheme for Waiting Well, and this will involve voluntary sector organisations being able to provide services to patients who are on waiting lists to support them during that time.
And actually, very convenient, Professor Tony Young just wandered into the room, who's the National Lead for Innovation, NHS England. We'll be hearing from Tony later. But I was looking over to my left to our Encompass team as we were talking about communication. And obviously, we have the unique situation now where we have a single electronic healthcare record for all of the secondary care trusts in Northern Ireland, with the additional MyCare. And I think one of the things in conference that we're seeing is everyone is now saying, let's make MyCare work, and how do we make it really interactive, and how do we have lots of communication between the clinicians and the patients. So let's dive a little bit into the clinical arena, and then I would like to come back out around the room. I see lots of people that are not shrinking violets, like Dean Sullivan, who might want to ask a question in the room. So we're going to go around the room again second. So Niall, obviously you're the Regional Director for the College of Surgeons, and this is an active space that you are in, and you probably get an idea from our Welsh colleagues, from our Scottish colleagues and English colleagues that we're all struggling to deal with that rising demand capacity. So do you want to give us a sort of flavour of what thoughts so far on some of the initiatives that you're aware of?
Thanks, Mark. I think what you just said there, it's the perfect thing. The solutions are more complex, but I think the question and the primary solution is probably a bit more simple, and it's demand and capacity. You know, our waiting lists have gone up and up and up because we don't have the capacity to deal with the patients that we're putting on waiting lists. You know, it's simple health economics. So it's how do we look at increasing that capacity? And a lot of the things that we've looked at is things like the surgical hubs, the elective overnight stay care centres. It's removing that non-scheduled care and elective care being in the same place, because unfortunately the unscheduled care often impacts on elective care. So where we go to our surgical hubs and ring-fence beds, we can continue to deliver that degree of care. One thing that we did learn in COVID as well was that almost immediate suspension of elective care and surgery. We're still picking up the pieces from that 5-6 years later. I mean, that was a disaster. So I think we have to understand that no matter what happens and goes on within our health service, we have to have a very simple background amount of activity to ensure that we're delivering that care. I think some of the stuff that Rosie has talked about as well is the mega clinics, the bringing patients up and reassessing them as well. We've done a lot of work on that. And it is about having those conversations with people to say, well, actually, you know, you were put on a waiting list 6, 7, 8, 10 years ago. The indication for your operation was entirely correct at the time. And if you'd had your surgery at the time, it was entirely correct. However, over that period of time, things have changed. Your condition has changed. Has your condition sort of continued on as part of the natural progression of that disease? Or, you know, how has your health otherwise changed? Because your risk may have been sort of an average risk 8 years ago. Your comorbidities and your overall health in the period of time in between have changed, so that now there is a difference in that balance between the indication for the surgery and an indication not to actually do anything. So I think those are. Our workforce is very important. As a college, we will be producing a new census before Christmas. So looking at some of that data again, it's much like the census we produced before. We have a very tired, burnt out workforce. We have a surgical workforce that's, you know, people down into their 55s are considering retirement. And I don't think we can afford to lose those people. Most of them are very experienced surgeons. Most of them deliver very well. And if we're sort of allowing this to happen, we don't have the same number of people coming in. So we need to increase training, and we need to increase the number of people coming back in. I think part of the elective recovery plan for England is important as well, is for addressing those increases in waiting lists. You know, as surgeons, we often find that we get people referred to us, to our clinics, who really don't need to be referred. And it's a bit more engaging with Ursula and our colleagues in primary care, where there's a more of an open door policy to say, look, I have this patient, I may consider referring them to you, but is there any advice you could give me in the meantime? And, you know, GPs, what is it now, paid in England, £20 to do that referral instead. And that saves them things, and it takes, you know...
and that's that advice and guidance, and
yes,
how we can maximise that. And I know Ursula will come back. Now, I'm conscious of time, and I'm going to go to Rosie. So Rosie has been instrumental in many aspects of pre-operative elective care frameworks, not only locally known nationally and internationally as a very respected anaesthetist in the areas of pain and pre-operative. Rosie, give us a flavour of some of the early wins that we have had, I suppose, and maybe add a little bit of an international flavour to it.
Thanks, Mark.
So it's really interesting what the panel have said already, and it all links in so much together. So we have an aging population, and we have a population who, when they are waiting for surgery or waiting for any kind of procedure, do become more unwell. And as we invest in the sites like the elective care centres and the day procedure centres, if you have patients who are not waiting well, they can't utilise those centres. So then what happens is that you're trying to decant more elective care into our sites where we're doing urgent care, cancer care, unscheduled care. And that just doesn't work, because that's what we've been doing for years in Northern Ireland, that we've been putting everything into the sites that need to do that. So we really, really need to work harder to be able to support those sites, to be able to do sicker patients, but also to make sure our patients don't get to that stage before we do surgery. We're currently doing a large amount of work on preoperative assessment. So for those of you who don't know, if you come for surgery, you'll get assessed by usually a member of our fantastic nursing staff or AHP staff, and then you'll potentially see an anaesthetist as well. At present, everybody goes through the same process. So if you're young and fit and well, you'll probably go through a similar process than somebody who maybe has a lot of comorbidities. What we're trying to do with that is to try and to use all of our digital support that we now have within Compass to be able to extract patients out quickly. So have a light touch technique for about the 20% of patients who don't need a lot of pre-op assessment. But then in those high risk patients, which in Northern Ireland is around about 20, sometimes 22% of patients who are really high risk for surgery, to go back to that shared care model, to really work with our patients and work with the data that we have to be able to say, you're going to have this procedure, be it a surgical procedure, be it any kind of procedure. Here are your individualized risks for that. Because actually, for a lot of people, when they come to surgical outpatients already, they just assume that an operation will fix everything. But actually, in a lot of cases, if you think a simple hernia, for example, up to 20% of patients post-hernia have a lot of chronic pain. And whenever you actually explain this to people, if you've got something that's slightly annoying, but having an operation will make it worse, we're very bad here at actually saying that. So we're very bad about actually talking to patients about what their personalised outcome is going to be. And that's where I think Encompass is really going to help us, is that we're going to be able to put all that data in, and we're going to be able to say, for you, a 78-year-old gentleman who has these health conditions, this is what your potential outcome will be, and so that the patient and their family will be able to make a much more informed decision, because I think we're not working so well as that. And that links in again with all the waiting well and the communication. It's critical that we look at patient-centred care. That is the most important thing.
Perfect. So we've got about 7 minutes. I'm looking at artistic license here. So we're going to do rapid fire questions, quick introduction, quick question, and we'll try and get as many answers as possible. I do want to bring Mabon in. We have one of our Welsh Assembly ministers, and I just would like Mabon to bring you in as well. So your question, sir.
Hi, Gurjinder Pahal, Medical Director of the Surgical Consortium and the Director of Plastic Surgery at Barts Health in England. We've removed some 50,000 patients from the waiting list in England over the last 5 years, and we've done that by employing lean methodology and leveraging technology. So to the panel, how do you see technology and lean methodology in assisting the waiting lists here in Northern Ireland?
Yeah, a really good question. I'm going to get Rosie to come in first.
Interestingly, we've done an awful lot of work on actual waiting list validation, and we've used even just the most basic digital QR code, sending that out to patients, and we've removed so many patients from the waiting list who either don't want their surgery anymore or terrifyingly have had their surgery already, but because we haven't had the digital platform until now, that we've just, a lot of our waiting lists, we just didn't have control of them. We didn't know where that was. So it's really interesting to hear, and I know colleagues across the water have done a lot of that. A lot of what we see in the data is actually not quite correct. We talk a lot about the 7 and 8 year waits. That could just be a few patients who are waiting because they've got chronic health conditions. So targeting them, and what Lisa's doing is actually, it sounds terrifying here that we've got these 7, 8 year waits, but overall, and that's why it's critical with the data, is to see that most patients are not waiting that long, but it allows targeted assessment rather than just this sort of scattergun approach. Maybe Lisa or Ursula, you want to take that?
Ursula, quick point, and then we'll go back, because again, primary care, really important, and also don't forget elective care in primary care.
Well, I was going to probably just talk about that, Mark, if that's okay, because I haven't had a chance to kind of fly the flag for primary care, so to speak. So I'm going to say that over the last 7 years, there have been 70,000 patients who have not made it onto a waiting list in Northern Ireland because they've been dealt with in primary care through the primary care or GP elective care service. And this was initially designed to try to ensure that patients who could be managed in a community setting did not go on to a waiting list, and there was another alternative to referral into secondary care. And it's been absolutely transformative for patients, but also for the GP community. It's allowed some of our GPs with enhanced skills to really develop those skills and to deliver for patients right at the heart of their communities. So kind of before our time in terms of transformation and shift left. And what we've seen is across women's health, across musculoskeletal medicine, dermatology and vasectomy, that those 70,000 patients have never made it onto your lists, have never made it anywhere near a hospital setting, and have had their entire care carried out by GPs in the community. There's huge opportunities for us to develop that and to enhance that, and to ensure that only the sickest people that need to have a procedure or an outpatient appointment in a secondary care setting does so. The other point that I would make around that is that we've talked about pathway development, we've talked about what happens when a referral makes it into the system, because as gatekeepers, yes, of course, we are responsible for a proportion of referrals, but it's also important to note that other parts of the system refer into other parts of the system. But as GPs, we probably could have a very integral role in helping design pathways for patients, because fundamentally at the outset, we are the patient's primary advocate. And Rosie talked about having those discussions around personalised outcomes. You know, we are at the centre often of those conversations, so there are lots of patients who don't make it onto a waiting list from the get-go because we have those conversations. So data will help us as well, but from a GP and primary care perspective, actually sitting down with colleagues who are designing pathways in a hospital, we will help and can help, and I am offering that help now.
And we're taking that help. I have one quick question. I know the next group, I do not want to stand in the way of Professor Tony Young and Dr. Paul Rice for the next session, but also I'm scared of Jennifer Neff. One quick question? Any quick question? Oh, yep, go ahead. Sorry, I know you tried before. Quick question, really quick answer, and then I'll close.
My name's Claire Wilson. I'm a specialist speech and language therapist in the Western Trust. And my question is really in relation to something that Danny had said there about we need this workforce in order to help tackle the waiting list, about recruiting and retaining. So my question really is, I'm curious, have you considered staff in the waiting list whenever they become a service user and they're then not able to do their job or come in and meet the needs of their client group? So
that's a wonderful question. How do we get the troops back to the front line? Who would like to take that? I'm directed towards Ursula quickly, and then Lisa maybe, and then we'll close.
It is vitally important that we look after the people who look after our population, whether that be from a physical perspective, or certainly one of the big things that we've seen is burnout and the emotional burden that that we all take on as frontline caregivers. We need systems and structures in place to support our workforce and to retain them. We're seeing folk leave all the time, and I certainly know from a GP perspective, retention is a big part of our challenge. But unless we put in place those systems and structures, and Northern Ireland's the only place across these islands that doesn't have a practitioner health programme to support staff, and that would go some way to actually help manage the concerns that we have about retention of staff. But it's only one aspect of it. There is absolutely something about making sure that we, as the front line in terms of caregivers, have access to good quality care.
Okay, so Donna Traynor come into the room. That means I'm in trouble. Terrible chair. Can I just close by thanking all our panel? I hope you would agree, united we stand. Divided we fall. Everyone, I can assure you, we will all continue to work collectively to fix our waiting lists. Once again, my thanks to everyone. Thank you.
We'll go into our next session, which is celebrating our innovators. So proactively adopting innovation is highlighted as one of several new ways of working in the Reset plan, with significant potential, as you know, to drive value achieve better patient outcomes, and support economic growth. We would hush. Now, in this session, we will explore why accelerating innovation is so important. And they're so enthusiastic, they've taken to the stage already, even before I introduce them. So please welcome all together Dr. Paul Rice, Chief Digital Information Officer at the Department of Health, Jennifer Neff, who is our entrepreneur in residence, and Professor Tony Young, Chief Scientific Officer at the Department of Health as well. Our panel, ladies and gentlemen, give them a wee welcome now. Microphones, guys, that's great. You can share that. I'm very keen to get your questions in regard to innovation and implementation. In the previous session, we heard how with innovation, so many things have happened in our health and social care system. I was in the AI parallel session there recently, with a link from Great Ormond Street, and talking about all the fantastic innovation that has gone on, in particular with surgery. So let's start in regard to celebrating our innovators, and so much innovation coming out of Northern Ireland as well. Paul, it's a key part of the Reset plan, innovation and also investment in research. So what are the ambitions there?
So I think what we've seen this morning is the way in which the economy, the Department of Economy and the Department of Health there's a hand clasp there at the moment going forward that says that health and wealth agenda has to be pursued in an equal and equivalent way, that ostensibly good jobs, I mean, we've obviously heard about housing, we've heard about other broader, from our First Minister and Deputy First Minister earlier about the extent to which, life chances are impacted in so many ways. But I think it's been fundamentally important to see how health and economy are linking, and intend to elaborate on that partnership going forward. It's not always about beg, borrowing and stealing stuff from across the water, but there has been quite a mature model for a number of years where academic health partnerships form to ensure that the research base and the expertise in the universities are plugged into the outstanding needs for the population. You've then got another essential link in that chain around health innovation networks, and we have Hirani in Northern Ireland that does a job very similar to a health innovation network, but we absolutely have to turbo power that going forward. And then we need the pull from the trusts. And I'm not saying we need to pull from the trusts because we don't have that. I think, as you've demonstrated, we've innovation coming out of every pore in Northern Ireland and in our health and care system. We wouldn't have recovered to the position that we have recovered to today, and that Mark and colleagues outlined in the last session, without that innovation. But we can still do more, and we can still be clearer that that relationship means that the needs of the population, the requirements of our colleagues delivering care, are fed through end to end across that process. So that's the aspiration and the ambition. It's to maybe overleap our colleagues in some respects across the water, or our colleagues in the Republic of Ireland. But it's about the essential relationship and interconnection of those parts. And it's about the opportunities for investment that we have on an all-Ireland basis, or on a city deals basis, or in other sort of other income streams. We need to get that system well-oiled. We need to get it frictionless, and we need to get the right alignment between the real insights that our innovators have, because they are often, I've been upstairs yesterday and today, these people are coming from frontline context. They're responding to things that they've seen and felt in their professional practice need and can be improved. We need to get that relationship end to end, slicker, faster, frictionless, all of that sort of experience. That's what we need.
A lot of our talk over the last couple of days has been about the neighbourhood model, early prevention, and things that are happening on the ground. Do you think we have a disconnect there? We talk about Encompass and all the benefits that have happened within the secondary care sector. What about in primary, in particular within the communities? Do you think we're not there yet? Definitely.
So I started my day today at a 8:15 in one of the rooms upstairs, with some of our primary care leaders talking about, again, constructs that people be familiar with, virtual wards, remote monitoring, telemetry, all of that there is an engine room there for innovation around primary care. Some of our primary care clinicians are actively involved in that work today. Is it systematic? Is it universal? No. So is there an opportunity to expand that and scale that? I think absolutely, and I think the neighbourhood model will be the manifestation of that going forward. But it's about every sector almost simultaneously. You know, that family unit is not just general practice, it is our community pharmacists. Again, you know, many of those innovators, but equally in some respects, some processes we have got that are paper-bound and paper-based, and we need to eliminate those because, you know, we've heard a lot about data and the richness of data. We've also know that those investments in Encompass were because you ain't going to get that data out of paper. You ain't going to get that insight out of paper. So yeah, we've got a job to do in all of those sectors to step forward from where we are, but I remain confident, as a number of speakers have in the last couple of days, that we are uniquely positioned to leverage that.
Jennifer, an entrepreneur in residence at a health conference. When I read it first, I went, what? So what is an entrepreneur in residence?
Well, I have a background in innovation myself. Having Leanne Monk and I came up with an idea and a concept that really, really took off, and 20 million users. But basically what it was doing was activating that neighbourhood model through social prescribing. And there's lots of rich data that came from that, and it was connecting primary care, social care, mental health, and all the different disciplines. So I've been through the wars, so to speak, in terms of coming up with an idea, getting someone to test it, getting the evidence, then getting some traction and scaling that solution and basically getting it adopted. So very popular in England, Scotland and Wales. Northern Ireland, not so much so. So I bear the scars, and that makes the good basis for being an entrepreneur in residence. So what my task was, I was working really closely with Joanne and Harani, with Heather and Rhonda Campbell in HSC Innovation. And what we said was, let's create a space where we bring health and economy literally together. So we had 13 entrepreneurs over the course of the 2 days, people with lived experience who have made the bold move to say, I understand the challenge that's faced by the sector. I'm actually going to do something about it because I don't see a solution out there, and I'm going to put my life on the line. And that's because that's what you're doing essentially when you're coming up with these ideas. You have to put paid jobs on hold. You're often working for no salary, but you believe passionately in what can be done, the change that can be affected. And we spend millions of pounds in the economy side of things, helping businesses understand the challenge that they're addressing, helping them to scale with the technology, with the support. You have a host of organisations, and often what happens, if you're in health and social care or health tech or life sciences, you get to the door of the health side of things and it's like, oh, no, sorry, we don't have the budgets, we don't have the space, we don't have the clinical champions. So what we were trying to do over the course of the 2 days was break down some of those barriers. We had people from across system leaders coming up to the space in the mezzanine and chatting with our innovators. And they were asking them the hard questions like, how do I get, I've got a pilot here, how do I get this beyond pilot? I've got the evidence. It's proven that it's making a difference in terms of dementia care or in terms of mental health. How do I scale that now cost effectively across the region? Because often if you do it across the region, you get a better price for it. So you're going to be saving money rather than doing trust by trust.
So introduce us to some of the creative people who you've brought up to the Innovation Zone. They're in the audience.
Yeah, just by chance. I forgot about that, actually. I was supposed to do that. And just by chance, Donna.
That's why I'm here, Jennifer.
Thank you. Some of them are here today. So I want to introduce...
Heather has a microphone there,
yes,
so we'll
brilliant,
get to
brilliant.
talk to
I want to introduce you, first of all, to Stephen Toland and Neil Sharp from Consulted.
Stand up there, guys. Thank you. You're very welcome. Tell us about your innovation.
Hello, everybody. As Jennifer alluded to, so my name's Stephen, pharmacist by profession. Along with my fellow pharmacist, Neil Sharp, we are the founders of Consulted. Consulted is a digital consultation and triage tool. It's been built primarily for the pharmacy support staff. What I mean by support staff is not the pharmacist. Over the past 17 years, we have seen these problems whereby all these new services are getting introduced, but the support staff just don't know of enough about it or how to signpost to it. That's what we do, along with a particular emphasis on over-the-counter medication. So that first point of contact is so important, and it's the first real pivotal intervention point, and so Consulted helps staff basically navigate that.
And what Stephen and Neil have been able to do is already, within the small pilot, been able to demonstrate that they can reduce the amount of people that are having to go to primary care because they're being supported in their own pharmacies. So we need more pharmacies now to be able to be supported to adopt Consulted and get that evidence back into the system again and be able to really, I suppose, drive that revenue stream through for pharmacies as well so that they can still stay open and provide an important role.
Paul?
And I think the interesting thing we're hearing there is about the multiplier effect of a change in the construction of the workforce and then giving that skilled workforce the tools that make them operate at the top of their game. So you have two things going on there in tandem. You've got understanding the extent to which pharmacy practice is not singularly vested in the pharmacist. There's a whole workforce out there who are skilled, and then you've got the technology to give them an opportunity to be as effective as they can be in their practice.
And they've just taken on investment, pre-seed investment of £250,000. So this is angel investors who are believing in this product and this team to be able to make a difference. So that should get, that's where we should all be wrapping our arms around them now and saying, okay, how can we make this adopted across at scale?
Well, you're too far away from me to wrap my arms around you, but congratulations. A round of applause for our innovators there.
Okay, and next up we have Claire Brannigan from Skin Akin.
Hi everybody, I'm Claire. I'm the founder of Skin Akin. Most of my life I've worked in economic development, but I stepped out of that last year to focus on the business. As a mother of four, two of which have eczema all their lives, I've seen the impact that it can have and how difficult it is for families to manage. And I was completely fed up with the solutions on offer, so I decided to do something about it. So I've created a range of therapeutic garments, and we're developing wearable solutions to help people manage eczema better at home. As I've went through this journey, I've also learnt about the impact on the health sector. So a recent report said 3.5 billion cost over 5 years just down to eczema. Around 30% of that is in direct healthcare costs, and the rest is lost in productivity, poor educational outcomes, associated conditions, etc. So I want to do something about that. My garment range is going through regulation and compliance at the moment and will be ready in December. So I want to do a feasibility study here in Northern Ireland. I've had interest from clinicians in England, which is fantastic, but I really want to do this at home in my own community and show people the impact a little bit of innovation in this space can have on people, improving their quality of life. My wearable proof of concept will be finished in January next year. So if you're interested in exploring and shaping the future of data-led skin health, please connect with me. I'm upstairs in the mezzanine and I'd love to talk to you.
Thank you, Claire, and the best of luck. Again, someone at the coalface, someone who knows exactly, is looking for a solution because they know the effects of it.
And lived experience, which is the thing that all of these are coming out of lived experience. So there's a box ticked straight away in terms of people that understand the challenges associated with some of the issues.
So who's next?
Next up is Ryan Ford from Medical AI Solutions.
Thank you for the intro. Good afternoon, everyone. So recently, myself and my family have been caring for an elderly relative. She was suffering from the early stages of dementia. We searched the market for a relevant solution to assist with managing her medication, as that was probably the most difficult aspect of the care. Having searched the market, we found nothing, and with the accelerated adoption of AI, I thought there had to be a way of developing an accessible, effective, and scalable solution. So with that thought, the idea behind Medical AI Solutions was formed. We've developed an AI-driven telephone reminder system that delivers medication management support to patients outside of the clinical setting. So it's a way of differentiating from complex apps and hardware solutions that many older people can't use. Insights from the conversations are then fed back onto a healthcare provider portal, providing them with information they need to improve their care. I'm interested in speaking to anybody that can help me put this technology into the hands of people in the demographic we're targeting, which is older people managing multiple medications. We're upstairs and can demo the solution to anyone who's interested.
Thank you very much and congratulations. And as our population gets older and we have an increase in dementia cases, all the more reason why we need that sort of practical help.
Exactly, and Ryan's one of our youngest entrepreneurs. Ryan could get a job anywhere, but he's decided that this is what he wants to do. And thanks to Connected Health for providing a domiciliary care test environment for Ryan to do that. So it's where does Ryan go from here now? So if there's anyone here that can support with those next stages for Ryan, he's been on the Founder Labs program. Moic's been a great support as well, and Harani. So it's where can we take Ryan next?
Okay, and who else? Have you another one?
And finally,
this is your last person.
Yes, finally, this is Frances Duffy from 6D Dementia.
If you were lying in bed this morning and two strangers come in and started to remove your clothing, you'd be terrified. That's the daily experience of tens of thousands of people with dementia every day. My name's Frances Duffy. I'm a consultant clinical psychologist, and I developed 6D Dementia, a digital training platform for health and care staff to transform dementia care. We can support all aspects of the Reset plan. Just as one example, 30% of admissions to hospital for people with dementia are for social reasons, not medical reasons. That shouldn't be happening, and we can change that. Currently, we're scaling across an ICB in the UK, where we're offering training to NHS staff, local authorities, and voluntary organisations. I would love to work with organisations in Northern Ireland so that we can bring good quality dementia care here to improve care and also reduce costs. So please come and speak to me. I'm up in the mezzanine zone.
Congratulations. Thank you, Frances. And I only wish we were 4 dragons.
I know.
And had a big pile of money on a table in front of us and invest in all of these fantastic ideas. So it's very well, it's a hard start, but it's just a platform like this must be great for those innovators.
Oh, fantastic.
Like the connections.
And when you look at what Frances is doing, she's just about to announce that she's won a massive contract in BNSSG in Bristol in England.
Well done, Frances. Congratulations.
So, she can train teams at scale because of the technology that she's developed. So why can we not, I think all of us need to be saying, right, what can we do to help Frances as well? So to reiterate again, thank you to those that come up. But what I'm most interested in is what's going to happen now in the next 2 weeks, because we've had firm commitments from people to have conversations. There's other people we haven't spoke to yet. But the next 2 weeks will show us, is this something we really care about? Because they have the answers to a lot of the problems that we face. And my ask of Heather is, this time next year, can we bring those 13 on stage and find out how far they've gone and what are the good news stories out of that has been able to be a result that have been adopted here in Northern Ireland?
There's an old phrase, the squeaky wheel gets the oil, and no disrespect to you, but you are definitely the squeaky wheel, Jennifer. And I think Heather is listening to that. And it all goes to prove, Tony, how important the embracing of innovation and new ways of thinking and coming up with things that might work but might not work, but we'll tweak it and then it'll work for everything as we transform our health and social care.
People sometimes think innovation is nice to have, but it really isn't. It is mission critical for what we do. And I wouldn't call you a squeaky wheel, but a force of nature for transformation in healthcare in Northern Ireland. But sometimes you have to step away from home, don't you, to build success before you come back. And I think you're an amazing asset for Northern Ireland, the people there. It's been a long and tough journey. And I look forward to working with you and love it, as I do with Paul, I should say. I've been coming over to Belfast for the last 3-4 years now, working with Joanne and Hirani and trying to help establish kind of that culture and ecosystem, Paul, that you are fighting so hard to create in your role. And we don't have all the answers in England. We certainly don't have the money. We've got lots of really great committed clinicians, lots of great managers, lots of great support staff. who are really passionate and driven about making healthcare better. Look, you filled a room with people who are interested in this subject, and we don't need to give you permission to get on and do it. How can we facilitate you in that? And we've heard 4 great pitches. They're all wonderful. And I don't have a pile of money to give any of you, but Irani do support places on the NHS Clinical Entrepreneur Programme. Francis is one of them, but the others will be welcomed by. We also have a Dementia Innovators Programme sponsored by the Alzheimer's Society and a Patient Entrepreneur Programme, and applications are opening. And why shouldn't Northern Ireland have the biggest cohort of entrepreneurs that we support across the 4 home nations? And why can't we join that up with testing and trialling and work together? And I see a real willingness and a collaboration here in Northern Ireland to make that happen. So I don't want to go on and labour words, but I will come and ask. If there's something you want from me, come and ask me. I will do anything I can to help you try and transform patient care and the NHS here. But we also want to take that back to England and learn it there too.
Thanks, Tony. Definitely this platform, this last 2 days, it's been a shared platform. It's all about sharing conversations and making those connections. I've just time for just maybe 1 or 2 questions from the floor. Have you still got that microphone, Heather? Has someone else got a microphone just at the front here? Anyone else that I can see? No, I'll just take this question from the front. Thank you.
It's not a question,
It's a
so
statement.
somebody could be thinking of their question. But just to Jennifer's point about money, just today...
Just introduce yourself to the rest of the room. Thank you.
My name's Joanne Rose from Harani, so I'm Chief Executive of Harani, and we run the Northern Ireland Health and Life Sciences Launchpad in partnership with Innovate UK, Invest Northern Ireland and Belfast City Council. But it's open to anyone in Northern Ireland, any emerging business. We've got £1.1 million. The bids open next week. I think they close in December. So that's 11 of these projects that could be funded now. But crucially, that money, while it's business-led, they want to partner with people that can test and trial. So if there's somebody within the healthcare system that wants to lend their advice, if there's resources that you could charge for that will raise a small amount of revenue that will help you understand innovation better, some of these conversations that have been started today and yesterday could potentially lead into a project. We'll have to get our skates on. You've got 6 weeks to write it, but that will bring funding in and actually put some money behind some of these relationships to really build that. And then hopefully next year at NICON, we can come back and talk about those 11 projects that have been successful.
Thank you for that. In 30 seconds, I'm going to give each of you 30 seconds to sum up. Innovation, what will this do to transform our health and social care system?
So I was thinking about this on the way in this morning. It's a bit of a slogan, but I said introductions made, partnerships managed. There's an intentionality in this room today. We will be in a situation where we take up the offers that are presented, the outcomes will follow, but it won't happen by accident. We have to apply that intentionality and working across our ambition.
4 shifts,
treatment to prevention, hospital to community, people as partners, and a wee bit of underpinning of analog to digital.
So Jennifer, what will innovation do to transform and also for future generations make our health and social care system the best it can be, if not the best in the world?
Obviously, the big focus is on the deficit. So there's that 600 million, I think was I'd heard quoted. It has to be able to make a dent on that and show pathways to be able to freeing up some of that capacity, building capacity back into the system, make people love what they do again in terms of working in health and social care, but ultimately see a difference so that people in the community can actually see the difference that it's making. But we have to keep our eyes on the prize in terms of that money, and everything has to be about trying to make those cost savings but still deliver really excellent care.
Okay, Tony, what will innovation do?
If you want to find out what innovation will do, come to the Clayton Hotel tonight. Because we're hosting the Clinical Entrepreneur Programme. It's our Belfast pit stop, and you'll both be there. And they say there's no such thing as a free lunch, but there will be a free dinner there and networking. But it's not free because we want you to roll your sleeves up and come along and try and help make some of the things we've heard here tonight, this afternoon already happen, but other things too. So I think how you make innovation happen is by coming together as a connected network knowing how you make those introductions, how you learn from each other as a group, and then you move things forward.
Thanks to Tony, to Jennifer, and to Paul, ladies and gentlemen. It's great to talk about something so positive. Great ideas and great implementation, and the best of luck to our entrepreneurs, those here and those who are upstairs, who were trying to get some sort of collaboration and connection with everyone. We really wish them very, very well. Safeguarding the NHS for future generations are imperative for change. In our closing main stage session, we hear from the seasoned MP and former Health Secretary, Alan Milburn. And as a health and social mobility advocate, he's also currently a government advisor. Alan will share his perspective on why and crucially how we must accelerate efforts to safeguard health and social care services for future generations. Please put your hands together. A good Belfast welcome to NICON25, Alan Milburn.
Thank you very much indeed. I'm glad I'm not on the receiving end of all of that. So it's a great pleasure to be here with you today. It's a particular pleasure to be here with Mike, who's one of my oldest friends. And as you probably all know, you're extremely lucky to have him because he really is. He's an agent for change. And if anyone can reset the health service in Northern Ireland and help lead that process, it's Mike Farah. I've worked with him for 30 years, something of that sort. And occasionally we've actually done some good things, Mike, once or twice. And like I've read your reset plan, and I think it's great. It's got echoes in terms of what we're doing in England as well. So I got asked a brilliant question the other day by a friend of mine. It wasn't Mike, who asked me, do you normally know when you're in a fin de siècle moment, an end of cycle moment? And the honest answer to that question is that you don't, because history moves slowly, moves iteratively, might change day by day, and then one morning you wake up and something's changed and it's profound. I can only remember twice in my life when that's happened, when I could feel the pressure for change building and then the pressure valve exploding. One was at the back end of the 70s, when I was a young guy, just getting active in politics in the northeast of England. And it wasn't a great place to be. And Britain wasn't fantastic. It really wasn't. We'd just been cap in hand to the IMF, just come out of a 3-day week. Everything was slow and dark and burdensome and bureaucratic. And then Mrs. Thatcher came along, for better or for worse. I thought for worse. But everything changed. The economy changed, society changed, politics changed, everything changed. That was a fin de siècle moment. And the second time is now, because everything's changing. Politics, economics, society, technology, the environment, you can see it. Geopolitics is shattering. The consensus of the last 30, 40 years, benefits of globalization, free movement of trade, free movement of labor. All of that is being challenged by new forces of protectionism, nationalism. You see it everywhere. And people blame President Trump for this. It's nothing about Trump. Trump is a symptom, he's not a cause, because it's been going on forever. He might be an accelerant of change, that he certainly is. He's making the weather every single day, changing things. Might be for the better, might be for the worse, like Mrs. Thatcher. But change is endemic. So why is it happening? It's happening for 2 or 3 principal reasons. The first is that an economic reason. So since the global financial crisis across the UK, some growth figures out today for the UK economy. On average, the British economy has grown by 0.5% per annum since the global financial crisis almost 20 years ago. The trend line is around 2%. So in other words, if we'd grown a trend, we would have been 40% better off. People would have felt 40% better off. But we've become 40% poorer. And frankly, Brexit has accelerated that. So there are economic reasons why change is happening, because the model isn't working and people feel it. They feel it in their pockets. They feel it in their communities. And the other reason is social, because accompanying this slowdown has been the speed up in inequity, in inequality. The gap between the haves and the have-nots has got wider, spatially and socially. You can see it particularly concentrated in, it's not just a UK phenomenon, by the way, it's a global phenomenon across the world. Think about where that's concentrated. It's what we call the Red Wall in England, the Rust Belt in the United States, the east of Germany and a unified Germany. And this is where, by the way, by no coincidence, the populists of right and left have their political base for a reason. Because those self-same forces that have led to such greater prosperity in the world and less poverty, globalization, free trade, open markets, which were of such enormous benefit to the east of the world, 300 million fewer Chinese people living in poverty as a consequence of Deng Xiaoping's opening of the Chinese market to Western capitalism in 1978. You've never seen anything like it anywhere, at any point in human history. It's the biggest poverty alleviation program there's ever been. And it worked brilliantly for the East. But in the West, it produced losers as well as winners. Today, across the UK, only 1 in 8 kids from a low-income background will go on to be a high-income earner as an adult. They're locked into poverty and disadvantage. So unsurprisingly, people are going, well, hold on a minute. Something's not working. The economy's not working, society's not working, politics, which is supposed to put these things right, is not working. So what happens? People look for the outsider, not the insider, the insurgent, not the incumbent. That's what's happening in politics. That's what President Trump is. That's what Mr. Farage is. That's what Marine Le Pen is. That's what Mr. Mélenchon in France. They all are, whether of left or of right. This is going on at the same time as the pace of change, which is what you've just been talking about, is accelerating exponentially. Most of us, I guess, of our generation grew up with Moore's Law. Do you remember that? Beautifully sort of curving tide of innovation that looked like that. And now it's going like that. I did a speech the other day to an academic audience as it happened, and because they're clever clogs, aren't they? And they want to sort of put you right. So somebody asked me this question. He stood at the end of the speech and said, do you know what today is, Alan? I thought it was an anniversary or something that I'd forgotten. And I said, I have no idea. What is it? He said, today is the slowest day of the rest of your life. What did he mean by that? Today is the slowest day of the rest of your life. He was talking about the pace of change. So think about the pace of change in the last 5 or 6 years. Think about where we've been and where we are. Does anybody here believe it's going to be any slower in the next 5 or 6? It's speeding up. Think about AI. We're in the foothills. It wasn't even a concept 3 years ago. Now we're all using ChatGPT and beyond. We're talking about, as you've been discussing, how to introduce it, implement it, scale it within a universal public service like the National Health Service. This is accelerating. And look, overall, it's going to be a good thing, right, for the world. But it's also causing greater uncertainty, more insecurity, and people are feeling more discombobulated. So you put these things together, and we're in this era of change. Unprecedented change, at scale and at pace, like the world has never seen before. And people are uncertain about where it's going. They really are. And they're wondering whether the old order, the old institutions, are still working. State institutions, politics, the NHS, everything is under question. So what is all of that? Why is all of that relevant to us, the National Health Service? It's totally relevant, because we're on the front line of that change. It's happening everywhere. You know, wherever I go in the world and talk to health ministers or health ministries, 2 words are synonymous: health and crisis. Everywhere. And everywhere, health is struggling to keep up with the pace and the chain and the scale of change. Everywhere. Because these new forces are disrupting healthcare at pace and at scale. And that's why reform is on the agenda everywhere. You know, it's on the agenda here and in England for reasons, because we're having to cope with both new challenges and, I would say, as you've just been discussing in your last session, new opportunities. And here's the thing about the lexicon of health. When we're discussing these issues, what's the language that we use? Normally we talk about the challenge. It's all about the challenge. We never talk about the opportunity. It's hard. What you're doing is hard. What we're doing in England is hard. It just is. You know, we've got a business model that's broken because there's not enough money, and there isn't going to be because of the fiscal position. You've got an operating model that doesn't work anymore because it's all being run from the centre. It employs 1.6 million people. That's impossible. And you're trying to drive the system harder to make these big changes about improving waiting lists, improving GP access, at the same time that there's very little money around. So these things are very, very, very hard to do. But honestly, if we don't walk into the new world with a sense more of optimism than pessimism and a lexicon in our heads of opportunity rather than challenge, the ability to do the reset and to make the shift is so much harder. So what I want to say to you today is, look, there are 4 things that are changing healthcare in the world. And normally we think about these as challenges. And what I want to do today is just briefly reframe them as opportunities. So the first challenge we talk about is demography, is aging populations. It's true. It's a good thing, not a bad. At least for my age group, it feels like a good thing. There's a prospect of something ahead. There's some runway. I mean, there's more behind than ahead. But anyway, it's sort of, you know, there's a bit to look forward to. And this is not going to be old age as we've known it. It's going to be more old people living with more comorbidities than we've ever seen before. And that will require, of course, investment in elderly care. It will require more seamless care. But for my baby boomer generation, it will require something else. Because we are not going to tolerate a system of care that tells us what to do. We're going to want to tell it what to do. The challenge is the obvious one, that the new generation of the old won't tolerate that old system. The opportunity is, how do we refashion care so that it is genuinely aligned with that more independent mindset? The second challenge is illness, malady. So the challenge of the last century was all about infectious disease, and none of that has gone away, as we've seen recently with COVID. The big challenge is about chronic disease, of course. Diabetes prevalence worldwide is going to increase by 50% during the course of the next 25 years. Long-term conditions now account for, 70% of healthcare expenditure in the NHS. So today's National Health Service is no longer just a safety net to protect people when they've the bad fortune to fall ill. It's the continuous provision of services for those who are already sick. And what differentiates chronic disease, whether it's diabetes or arthritis from other forms of illness, is that they become a permanent fixture of people's lives, 24/7. So what patients do to manage their own condition, their lifestyle, their diet, their exercise, is as important as what any clinician does. The challenge is the obvious one. How do we move from episodic care, in which patients are treated as passive recipients in a system that tends to deny them power and responsibility, to one which there's greater continuity of care and which patients have greater responsibility and greater charge of their own health? The opportunity is to bring patients inside the decision-making tent, to share the dilemmas that we as politicians, as managers and clinicians face every single day, rather than keeping them outside. But that requires a leap of faith, and it requires a transformation mindset. Third, expectancy. We live in a world where people are more informed and they're more inquiring, the young particularly. They're demanding a greater say. Ordinary people are getting a taste for greater power and control in their lives. It's just a fact of life. And healthcare, which all too often in practice stands as exempt from those sort of changes, we are analog, not digital, it can't stand aside. It's got to be part of, and indeed, in my view, it's got to lead that change. People, especially the young, want choice and they expect quality. It's not that people necessarily want a surgery or a hospital to behave like a supermarket or a sale room. What people want is not a transactional relationship, they want a personal one. A personal one. The challenge is to find new ways of treating each patient as an individual rather than just as a number. The opportunity is to harness that modern appetite for knowledge and control in order to make a reality of what we've talked about for generations and not been able to do, which is self-care. So the starting point in any new system has to be about what I do for myself, not what the state does for me. And fourth, and most potently of all, money. In the last 3 decades across the OECD, health budgets have risen faster than the economy has grown. In 1960, a long time ago, developed nations spent on average 4% of GDP on healthcare. Today, it's between 10 and 11%. Global healthcare spending by the end of this decade will be over $11 trillion. At the beginning of this decade, it was $9 trillion. The old argument that healthcare simply needed more money, in England at least, has collapsed, as more resources have failed to deliver corresponding improvements in either performance or productivity. It's quite remarkable. The previous Conservative government got absolutely zero credit for this, but the number of clinicians that it put on over the course of the last 6 or 7 years, in some ways, was quite remarkable. It was a hockey stick effect. Number of clinicians rose, the amount of productivity fell. So there is something going on. And you can see in the lead up to the budget for the UK government, Rachel Reeves has got some pretty difficult choices about what to prioritise and what to not. But what is obvious is that the old era of more for healthcare is over. And we are going to have to find ways of getting more out for what we put in. By the way, this is a global phenomenon too. It's all now about value-based care, and that is a huge challenge, but it's also an opportunity. And I say that for this reason. If you look at any other sector of the economy, improvements in quality have been matched by reductions in cost. Think about your price of your car, or your cell phone, or your computer. They've got better and they've got cheaper, but not in healthcare. And we have to become part of that new normal. Doing more with less and doing it better, faster and cheaper, that does have to become the new normal. And here, I want to give you the real grounds for optimism, which was partly reflected in the last session that you had. It's all about technology, folks. The future is all about technology. The world is at the beginning of what should properly be described as a healthcare revolution. Whether it's nanotechnology or quantum computing, technology is going to change everything about healthcare. And it won't just be about getting access on your mobile phone to a doctor or nurse. That's already happening. The big shift that we're going to see is in the collision of data analytics and genomic science, where these things come together, we should be able to move the paradigm of healthcare from one that's been about diagnosing and then treating people to instead being able to predict and prevent. That is the genius of what data analytics and genomic science are going to be able to bring to the world. And the wonderful thing is that many of these changes have the potential, at least, both to improve outcomes and contain cost. Inexpensive gene sequencing is an example. Gene editing, which can cure diseases. Vaccines, which can treat and prevent a whole series of chronic illnesses. In the next decade, genomic science will reveal the secret of a baby's genomic makeup. In England, we've just committed to genetic testing at birth so that parents from the outset, from the get-go, can understand what the risk profile of their child is, and hopefully the health service can work in tandem with them, in partnership, to use your word, in order to be able to mitigate the worst impacts. That will be a seismic shift in the health landscape. It is a huge change, but it doesn't stop there. Advances in AI will accelerate drug discovery, extend the predictive nature of genomics. This AI will also be an early warning system, detecting subtle signs of health changes by analyzing data from wearables, lifestyle, medical records to trigger timely interventions at an individual and a population level. So in other words, pre-disease states, before a person displays any symptoms, will be identified and even targeted. This is just a flavour of not what is to come, but what is already happening. This technology revolution should allow us to get upstream of ill health and make a reality both of population health management and of precision medicine. It holds the key, in my view at least, to making healthcare financially sustainable. And that is why it sits at the heart of England's 10-year health plan. And here, another source of optimism for you. The universality of the NHS gives us a profound global advantage in harnessing those benefits. Advances in genetics and analytics by identifying health risks leave insurance-based systems, like those of the United States, far more vulnerable. So, there is a message here, which is as we look to the future of healthcare, there is more to be optimistic about than there is pessimistic. All too often, however, the story of healthcare is one drenched in pessimism. No wonder the biggest thing in short supply. Look, there are many things that we're short of in and around the National Health Service. You know what the biggest thing is? Hope. Hope. Without hope, you'll never generate change. Change can come about as a consequence of fear, and you've got to do, and necessity, and all of those things. But our job as health leaders is to generate something else. That's called hope. It's about a sense of possibility that this thing can be better in the future than it's been in the past, and there are real reasons why we should feel that that is the case. So these fundamental changes produce, for me at least, an unprecedented opportunity to transform what healthcare can do and how it's delivered. But if we're to harness the benefits of that technology revolution, our mindset as leaders has to fundamentally change. From one that is about business as usual and managing, to one that is about change and transformation. The potential it brings to create services that are less about dealing with sickness and more about creating better health will mean profound change across all of our healthcare systems. We'll need new types of skills in the workforce. We'll need new infrastructure in the community. We will need reforms to how systems are organised and how providers are paid. If we can get these reforms right, the technological revolution that is taking place will form the building blocks of a very different healthcare system that will emerge in the years to come. Now, of course, the system here in Northern Ireland is different to that in England, and solutions will be different as well. And as somebody has just said, we should be learning from one another as we go. The 10-year plan, however, in England has at its core this idea. We have to change how we think of healthcare. Less as a narrow set of institutions that we happen to call the National Health Service, and more as an ecosystem of organisations. Think about the role of pharmaceutical companies and life sciences. Many are already forging new partnerships with local payers, with surgeries, pharmacies, not just to deliver new pills, but to deliver compliance and support services for patients. More and more retailers are looking to provide in-store instant access services for local communities, and we need more of that because they're on the high street. Telecommunications companies, tech companies have developed new home care service for elderly and infirm patients, and we need more of that too. So the healthcare system of the future will be an ecosystem, but it needs to be broader still. It will include organisations that influence broader health outcomes, including employers, schools, supermarkets, job centres. They have a key role to play, both in primary and in secondary prevention, not least in dealing with the tsunami we are seeking in ill health-related economic inactivity, which you were discussing this morning. It's both inhibiting economic growth and it's making our welfare system, frankly, fiscally unaffordable. So we all have a shared interest, employers as much as health services, in dealing with that problem. So that will require us to be far more intentional about building long-term partnerships. It will mean health ministries focusing less on managing an institution, the NHS, and more on convening a wider ecosystem of organisations. It will obviously mean a greater focus on how we ensure data interoperability, so we can draw data from three sources: clinical data, population health data, and this data that I have on my phone. And if we can put these three things together, it gives us the bank of data that we should be able to utilize in order to precisely do the prediction and the prevention that new technology enables us to bring. There are many other changes that are going to be needed to funding models, organizational models, and so on. But the biggest change of all, if the future model of care is to be sustainable, is to ensure that it is patients who are capable of exercising more choice and much greater control, which is why your third shift is the most important one. The others are just enablers. That's all they are. A means to an end. This is an end as well as an enabler. It is to deal with precisely some of the social, political, and economic issues that I described at the beginning of this speech. People are feeling a loss of locus of control in their lives. They've got these huge forces: globalization, deglobalization, political change, technological change, and people have got no sense of what is happening. And they have very little say over what is happening. The reason that this is so important is not just to transform healthcare, but to transform the relationship between the citizen and the state. Because otherwise, and you can see it in the data, look at the data amongst young people, this sort of creeping sense that democracy might be less good than autocracy. Autocracies get things done and democracies don't. Sometimes it's true. But the way to change that is, of course, to make sure that democracy and how our institutions, political institutions, work does actually work. But it's also by fundamentally bringing the public inside rather than keeping them outside. The truth is, unless we're able to do that, healthcare will face a tsunami of demand that it is simply unable to meet it. So think about mental health. Think about mental health amongst the young. Think about what's happening there. Now, it's a great thing that people are talking about their mental health, but if every stress, every anxiety, every low-level depression becomes medicalized and becomes the property of the state will simply be overwhelmed. So we've got to recalibrate that relationship in quite a fundamental way. And here, we're in the foothills of shifting that power paradigm. And in my view, it is the thing that we most need to accelerate. And you have an opportunity to do it here because you've made it your fourth big shift. Technology, again, is the enabler that can make that happen. Just as banks and airlines have moved power into the hands of individuals, the care model of the future should allow patients through their smartphones to book appointments, have online consultations, get results, even receive treatments. It will allow NHS patients to choose their providers. More significantly of all, it can help patients to look after themselves. The development of AI-driven personal assistants to empower citizens in proactive health management and to provide patients with enhanced diagnostic support and healthcare navigation is only one example of what is already possible today. In England, the NHS app will become the means to deliver these changes. Over these next few years, it will become the digital front door to the National Health Service. But making patient power less marginal and more mainstream means policymakers need to do more than simply get care systems to adopt new technology. They need to use patient-reported outcome experience measures to routinely assess how local services perform. That is what we're planning to do. In other words, what patients experience will underpin how local services are recognized and rewarded, so making them more directly accountable to the people who use them. And to take patient power to the next level, we're committed to ensuring that hundreds of thousands of patients, those with a chronic condition especially, have their own individual state-funded healthcare budgets so they can personalize care to their individual need. And here, the evidence base is really strong, both from the US and from the UK, that where people have direct financial control over their own health budgets, two remarkable things happen. Levels of patient satisfaction rise, and levels of public expenditure fall. The change in the future has to rely on the public being insiders, not outsiders, being part of the decision-making process rather than a bystander to it. And the reason why this is so important is that putting patients more in charge of their health and care is a means of doing something even more fundamental. It's a means of redistributing power in our society towards people who have the least choice and the least voice. Those people who are in the most disadvantaged communities who happen to suffer the greatest health inequalities. Now, that is a long way from where the NHS is today. In truth, it's too much top-down control, too bureaucratic, too monolithic. It is, in truth, too much still like the post-war era in which it was formed, and that really is not sustainable. The technology revolution we're witnessing provides the opportunity to redesign care systems away from their 20th century focus on episodic treatment, largely in hospitals, with patients disempowered, towards earlier preventative action and continuity in treatment in the community where patients have far more power. Here in Northern Ireland, you have the chance to lead that change. The great thing about this place is that it is big enough to make change in scale and yet small enough to get your arms wrapped around the execution of change. Of course, change takes time. It's not a coincidence that the plan that Wes Streeting has published in England is a 10-year plan. It's not a plan for one parliament, it's a plan for two. And it will take some upfront investment to make the transformation possible, in particular, to move resources from downstream to upstream. But money alone won't fix healthcare. In my time as health secretary, all of those years ago, it's almost a quarter of a century now, in fact, I think it is a quarter of a century, it was only when we made far-reaching reforms to give patients more choice, make the system more transparent, tie hospital payments to performance, and create more competition, that waiting times fell, outcomes improved, and public confidence rose. In other words, reform was the key that unlocked a better care system. What was true then is even more true now. An era of fiscal constraint means there will be less new investment in truth, and so we will have to rely on doing more reform. As leaders in healthcare, our job is very simple. Of course, we've got to manage it, but our fundamental task is to reform it. To do that, we have to be leaders, not followers. We have to look out to the world, not inwards to today's system. We have to focus less on what has gone on in the past and more about what is possible in the future. And above all else, we have to champion change, not continuity. As I said at the outset, this is an era of change. It provides for us enormous opportunities. We all need to embrace it. Thank you very much.
Mind yourself with all of those airplanes on the floor, that you don't bump into them. Thank you, Alan. The health revolution with technology at its heart, and to secure our health and social services for the future, social care for the future, part of that is predicting and preventing, such an important element, and giving people their say in their own health as well. Personally, as I close my bit today, I would really like to say how much I have enjoyed this conference. I have learned so much. I have met such inspiring and dedicated people. Thank you for all of the conversations, not just here in the main hall, but also in the corridors and all around the place. I've really, really enjoyed it, and I wish you well in your reset endeavours. I really do. Finally, I'd like to introduce to you, to close the conference, the Chair of NICON and the Chair of the South Eastern Health and Social Care Trust, Jonathan Patton.
Member of the Privy Council, Member of Senate Cymru, colleagues, good afternoon. Thank you for staying the course with us and still being here and investing your time with us at NICON. Into your own learning, and most of all, seeking opportunities to improve the care of patients and those we care for across our services. It's been an incredibly successful 2 days. As a management committee, it has far exceeded our expectations. I would remind you all that it has not been possible without our headline sponsors, BT, ABPI, and AWS. Thank you also to Donna Traynor for making it possible and hosting and the great job that she did. And of course, none of that would have happened, or none of that would have worked on its own without the incredible NICON team headed by Heather Moorhead. Would you please give them all a massive round of applause? I opened yesterday's conference yesterday morning by saying we're not in Kansas anymore. And that was to remind us of the uncertain times that we're in, and Kansas and the HSC is in our rearview mirror. NICON25 has come and gone. And the role I have, I often ask the question, so what? 2 days of conference, impressive speakers, challenging conversations, and innovative opportunities. Is that the sum total? Do we all revert to type and go back tomorrow and pick up where we left off and work in robotic fashion? Or are we ignited by the words and the people and the ideas and the innovations? If I move your thoughts from Kansas to Kentucky, where Dorothy already was in Kansas, but now in Kentucky. It's 1809, and on a small and poor and unproductive farm in Hardin County, a long-awaited son is born to Thomas and Nancy. We heard yesterday morning from Michael Marmot that kind of beginning in life can shape everything for the future. If you were at dinner last night, you'll have heard of Lord Victor talk about the difficult start that he had in the north of England and Wakefield, and a very disadvantaged start in life. But in Kentucky, with a caring, loving family and others around to support him, Thomas and Nancy's boy, Abraham, rose through his community and those around him to become the President of the United States of America. And when in office and speaking about his work, Abraham Lincoln said this: "The best way to predict your future is to create it." Let me say it again. The best way to predict your future is to create it. So as we face into language like deficit, collapse, catastrophic, do not let that language define you or us in HSC. We're better than that. I'm going back to my desk tomorrow to try again. Will you join me, and collectively can we create a future for those we care for and support?